I'd like to ask everybody to put their cell phones on silent. You may notice board members accessing their laptops, phones, or other devices during the meeting. They are using their devices to access board meeting materials that are in electronic format. This is an official meeting of the Medical Board of California. As such, disruptions of the board's business will not be tolerated. We have designated time on the agenda for public comment and ask for public comment on each item. I ask that you be respectful of the need to conduct the board's business. Should anyone disrupt the meeting, I will ask that person to conduct him or herself in such a manner that permits the board to transact its business. The board welcomes public comments on any item on the agenda, and it is the board's intent to ask for public comments prior to the board taking action on any agenda item. If for some reason I forget to ask for public comment on an agenda item and you wish to speak on that item, please raise your hand or come forward and you'll be recognized. I would like to request all speakers complete a presenter slip so that I can call you by name at the appropriate time and that a record of this meeting can be full and complete. However, this is voluntary. Please give the speaker slips to Ms. Cruz-Jones. Ms. Cruz-Jones, yep, thank you. I will do my best to call upon everyone who has supplied a slip for the agenda item and recognize those who wish to make last-minute comments. This meeting will be available via teleconference. Individuals listening to the meeting will have an opportunity to provide public comment and will be assisted by a moderator who will be facilitating the teleconference process. For those members of the public participating via teleconference, please wait until the moderator has introduced you before you make your comments. To request to make a comment during the public comment period, press *1. You will hear a tone indicating you are in queue for comment. If you change your mind and do not wish to make a comment, please press *2. Assistance is available throughout the teleconference meeting. To request a specialist, press *0. Each person will be limited to 3 minutes per agenda item. However, that time frame may be subject to change depending upon the number of speakers we have on a topic. During agenda item 14, public comments not on the agenda, the board has limited the total public comment period for individuals on the teleconference to 20 minutes. In addition, the total public comments for individuals here at the meeting will also be 20 minutes. Therefore, after 20 minutes, no further comments will be accepted. During public comment on other agenda item, 10 minutes will be allowed for the total comment period from individuals on the teleconference line and individuals here in the audience. After 10 minutes, no further comments will be accepted. Each person will be limited to 3 minutes per agenda item. Business Service Office staff will be assisting me with receiving the public comments via teleconference during this meeting. I want to remind all speakers to please stay on topic and keep your comments to 3 minutes or less. We plan to end today by 1 p.m. If you are in the media and require assistance or information, please see the board's public information manager, Carlos Villatoro. Do we have any more? Okay. I would like to call the meeting to order and ask that Ms. Cruz-Jones please call the roll.
Dr. Bolat? Ms. Friedman?
Here.
Dr. Gonadev?
Here.
Dr. Hawkins?
Here.
Dr. Kraus? Ms. Lawson?
Here.
Ms. Lubiano?
Here.
Dr. Lewis?
Present.
Ms. Sutton-Wills?
Here.
Mr. Warmoth?
Here.
Ms. Wright? Dr. Yip?
Here.
Ms. Pines?
Here. We have a quorum. I would like to remind the members again today that we will take roll call on any action items. Moving to agenda item 14, public comments not on the agenda. Before we invite speakers to come forward, I'd like to ask individuals making comments to not discuss pending complaints, pending licensing applications, or pending disciplinary actions that may come before the board for a decision. Such discussions are considered ex parte communications as they could provide information to the members that is outside of the record in violation of the Administrative Procedure Act. Therefore, such discussions could create a conflict and lead to the board decision being challenged in Superior Court. The board can receive comments regarding the board's processes in general, but it cannot receive comments on specific case circumstances where the decision is still pending. Board staff is available to speak with you about any pending matter. In addition, the board would like the public to address the board as a whole and not to individual members. Please be aware that public comment during this agenda item should provide information to the board members and is not a discussion between the board members and the public. The only action board members can take is to listen to comments and decide whether they want a future agenda item on the topic. No other action can be taken on the item at this meeting. Though this may seem at times like the board members are not being responsive, following these guidelines is critical to ensure the rules of the Open Meeting Act are followed to avoid compromising the speaker's goals or the board's mission. I have a few slips here. Eric Andrus.
So last night, as I was leaving, Dev and I ended up in the elevator together, and he said something very offensive to me. He said, "You should know better than to go to a bad surgeon." I thought, did he really just say that? Did he really put the blame on me for that surgeon screwing up 2 surgeries? Dev assumes that all patients have equal access to all doctors. When one is in an HMO, because they don't make much money as a volunteer patient safety advocate, they can't afford Cadillac insurance that lets them pick and choose doctors. This board is constantly telling consumers to use Breeze for information on their doctors. I did, and she had a totally clean record. Here's her record right here. In fact, I printed it out for you last night for you all to see. Patients looking her up back then or now would see this. Nothing. And why do they see nothing? Because this board closes 96% of the consumer complaints that come in, and closed my complaint against her after she damaged me for life. So Dev, next time you want to blame the victim, make sure the victim was actually the one that was in the wrong. Also, you need to listen to the Panel A hearing for Dr. Mark Hughes from yesterday, where the rep from the Attorney General's office recommended dropping the charges because this board, sorry, I'm nervous today, from this board's medical expert did a number of unscrupulous things. Here's a little tasting. Shoot, I just lost it. Sorry, now I'm going to run out of time. Okay, here it is. The first voice is Mr. Bell from the AG's office. The second voice is the doctor's attorney. Oh, shoot. Sorry, it's not going to work.
Had one expert who unfortunately applied the wrong standard of care for patient TW and was confronted with additional evidence of informed consent unknown to the board for patient NL.
There are only a couple of things that I think that should be added. Those of us who do this for a living know that the Attorney General relies entirely on the expert advice that is given to them. They're not doctors. And when the board investigates the complaint, they send it off to an expert for review. And they rely upon that expert's advice. In this case, the expert was, in our view, both corrupt, but also lied profusely in this case, and we don't know why. The expert did not take up the simple requirement of calling the board to see if those documents were on file before he opined that it was an extreme departure not to have filed them. This expert revised his opinions 5 times throughout the course of the case. Every time we read his opinion, we responded with how he was factually incorrect, and he backed down each of those times.
Your expert changed the facts in that case, changed his story 5 times, and this lawyer says that he was corrupt And we now wonder how many other of your experts are corrupt and how many of our cases, like mine, like Annette Ramirez, who lost her arms and legs and you guys closed her complaint, were closed by these corrupt experts. And we're going to start looking into this too, and we're going to take it to the national news network because this is wrong.
Thank you. Hannah Ree.
Eric, thanks. Good morning, medical board members and staff, everyone else that's present here. So I'm Hannah Ree, Dr. Ree again, with Black Patients Matter. And I want to maybe expound a little bit upon what I mentioned yesterday about bias. So we're utilizing the term of implicit bias, but I brought forth the term explicit bias. Look, we all live with biases. That's why we choose to live, work, and raise our families in certain areas and not others. Again, I want to reiterate that the medical experts working for the medical board are, of course, human and no different. And until coders are design algorithms to eliminate biases, we have to deal with, each other and human beings. As forward thinkers and innovators of racial diversity in the great state of California, Black Patients Matter is against funding an investigative and policing agency which pays medical experts who are not in active practice, and more importantly, who do not care for and treat a racially diversified patient population. How can they know what they don't know? I also want to utilize this moment here to maybe just state that we at BPM request that those who contact us by text or email, please do not send us any hate speech. Please do not send us any hate speech, text messages, or emails. We have moved past hate speech and grown into and evolved into becoming part of the solution and building bridges with the board in finding solutions. So I guess we want to also state, that in our federal civil rights lawsuit against a couple of members of the medical board here, we are deeply concerned that there are individuals with the medical board who are aligning themselves with non-racially diversified hate groups filled with hate speech and groups which are marginalizing Black patients. So I thank you again for your patience and your time in listening to me. And I brought some information which I think may be helpful. A short little statement about explicit bias and that sort of thing. So I thank you for your time.
Thank you. Do we have any other comments? Okay. Do we have any comments on the phone?
Thank you. There is one comment from Susan Lauren representing herself. Your line is open.
Hi, good morning, and I want to thank Hannah and Eric. You've both been very helpful, to me at least. How many of you on the board know that I stand up the whole time I'm on the phone with you? Please raise your hands. If you didn't raise your hands, you are not adequately aware of my case. I went in for a recommended breast reduction, and the surgeon took a power-assisted liposuction tool by Micro-Air that I didn't know about, didn't agree to, didn't at all want the back part of my body completely removed, but it's completely gone, and muscles are gone too, and that is the truth, and you can see it, and it has been recorded by many people, and this is a surgeon that should not be working. Now, as far as blaming the victim, I was highly referred to this surgeon by my physician, highly referred and exclusively referred. I did whatever research I could do. I was also referred by another plastic surgeon's office to him. I didn't know at the time about, gag clauses, under-limit settlements, online reputation management. I didn't know how corrupt the medical board was. He had a very, very nice office, and I didn't just believe him. It took me 4 months of questioning and going to other consultations, telling him my concerns, which he didn't listen to any of them, and I was mutilated. And you've done nothing. So clearly, whoever your expert is not an expert. I have a real problem with going to doctors who are doing scam surgeries to decide on other doctors who are doing scam surgeries, and that's exactly what's happening now. Yesterday, Eric said something interesting about the sugar coating of the minutes. He read something, and then he played something and then read the minutes. I didn't hear sugar coating. What I heard was lies. Now, the interesting thing is medical records are fabricated that simply and that sinisterly. When I was in the surgeon's office crying and saying, "Why did you remove my buttocks?" he wrote in his record, "She's pleased with her new breasts." That's what he wrote. I didn't say that. I'm not pleased that he took half of my healthy wanted breasts, left me completely scarred and pulled in pain, and destroyed the rest of my body and disabled me. You have criteria for procedures that are harmful, and yesterday Julie said to listen to the patient activists, of which I am one. We can prevent a lot of harm and death. For many years and with increasing concern, I've followed the way plastic surgeons are given carte blanche to do innately bad procedures, and when they kill or seriously harm one after another, which they would continue doing, they're treated as they're above the law. And this is not only deeply painful personally, but it's dangerous to all citizens. So I was extremely muscular with a small waist. I had some skin ptosis. I was not even a candidate, even in this crazy world of being a candidate for a really bad procedure.
Caller, please conclude.
Okay, well, I'll call next month, and I would like to put an item on the agenda to talk about liposuction and the cover-ups with your board, because one of your reviewers came and lied at my case, and he's one of the wealthiest doctors in the world.
Lauren, please conclude. Please put her back in the queue.
Put the caller back in the queue.
Are there any other comments on the phone?
Khadijah Lang, your line is open.
Thank you. Good morning, all. Happy Mother's Day to those of you who are mothers. I am Dr. Khadijah Lang, president of Golden State Medical Association, and I have 2 issues that I'd like to bring before the board this morning. The first one is that Golden State Medical Association is very concerned about the alarming, heretofore hidden and ignored epidemic of black maternal mortality in America. I describe it this way, as hidden and ignored, because the CDC and other government agencies have had this information for decades. This is a problem that started in the late 80s, but it has only recently become publicly known. For those of you who are not aware, currently the maternal mortality rate for African American women in the United States ranges from about 18 to 48 deaths per 100,000 pregnant women. This rate is 2 to 4 times higher for African women than for Caucasian women in the United States, and puts our nation at the bottom of the list of so-called developed nations with respect to maternal mortality rates. It also puts the United States rate behind many of the so-called underdeveloped nations. It is actually safer now for a black woman to deliver in many Caribbean nations than to deliver in America. And these statistics hold firm whether the pregnant black woman is rich, poor, high school dropout, PhD, insured, uninsured, had prenatal care in the first trimester, or had no prenatal care. Studies are showing that while many factors contribute to these devastating statistics, one of the most significant causes is racial bias and discrimination. It is the request of Golden State Medical Association that this board make it mandatory for any licensed personnel who comes into contact with pregnant women or could be anticipated to come into contact with pregnant women be required to undergo bias training in much the same manner that we physicians in California were required to get training on pain management and, most recently, on controlled drugs. As we approach this Mother's Day weekend, I think it is deplorable that in a country as wealthy as ours, with one of the best medical systems in the world, that our citizens are suffering from things that should have long since been managed. So I would appreciate your consideration on that issue. The second issue that I have is a much simpler one, and that is we'd like to request, Ms. Kirschmeyer, perhaps if you could give us an update. I'm sorry, I forgot. We don't address people directly. But if the board could please give us an update on how things are going with the handling of the findings of your 2017 demographic report. And
Caller, please conclude.
okay, and specifically with respect to the bias training that's being given for people at the medical board, I understand there were some concerns that it didn't seem to quite be adequate. What has been done to address that and get people who are culturally competent to be the ones planning and putting together and implementing the bias training that people are going through so it's not a wasted motion? Thank you for your time.
Thank you. Are there any additional comments on the phone?
There are no further comments on the phone.
Okay. So we're going to move to agenda item 12 from yesterday, which is an update on the Health Professions Education Foundation with Ms. Lawson and Dr. Hawkins.
Good morning. Dr. Hawkins here. I'll be brief, and I'll refer you to tab 12, 12.1 to 12.3. I'm going to start by just giving you remind everyone in the room what HPF is and what it does. I'm just going to talk about 3 categories of awards that we're very proud to have been able to give to California healthcare providers. So first, Health Professional Education Foundation, that's HPF, is a nonprofit 501c3 organization housed within the Office of Statewide Health Planning and Development, OSHPOD, established to improve access to healthcare in underserved areas of California by providing scholarship and loan repayment programs to current and aspiring health professionals who are committed to providing direct patient care. In return for HPF support, award recipients agreed to provide services in medical underserved areas of California for a period of 1 to 3 years. We met in March of 2019, that's the board met, and also on May 2019. All donations solicited on behalf of the organization should be used to further HPF missions and follow the procedures outlined. So we want to thank folks who actually participated in scoring folks for the first category of awards I'm going to mention. That's the Stephen M. Thompson Physician Corps Loan Repayment Program. And this one provides loan repayment programs for physicians who agree to provide medical care in underserved areas. So we had 275 applicants, 131 were not eligible, 144 applicants were scored. That scoring process, and I participated in that, involves ascertaining whether the individual actually has had experiences that would make them more prone to actually remain in an underserved area, whether they have experiences that would make them more culturally aware of some of the things that are going on in these underserved areas, et cetera. It's a process, and we want to thank again folks who also were involved in that scoring process. Approximately 42 physicians were awarded loan repayments. The cost of the awards, license fees, the cost of the award comes from license fees and penalty fees, and it was $4.41 million. That's the amount that was allocated to these 42 physicians for loan repayment programs. The awards are going to be sent out in May. The second loan repayment awards, and I want to emphasize that it's not just for physicians. So the second category is loan repayment programs for allied health. Those are the folks that read allergy techs, phlebotomists, those sort of folks. Bachelor of Science and Nursing loans, licensed mental health, and licensed vocational nurse loans. You'll see in your packet 26 for allied health, 120 for nurses, 27 for mental health, and 21 for licensed vocational nurses. And the last category of scholarships were 17 scholarships for nurses, and these are actually scholarship awards, $139,000. HPF is working hard, although we, at the present time, primarily get our financial support from license fees and penalties. We're actually aggressively working on fundraising and development to increase our coffers to give more money to deserving individuals who want to practice under served areas in California. That's the end of my report. There's more information available in this tab.
Thank you, Dr. Hopkins. Are there any questions or comments from the members? Any comments from the public? Any comments on the phone?
There are no comments from the phone.
Okay, great.
Thank you.
Thank you. Let's move to our next agenda item 15, presentation on the... Oh, okay, that presenter has not arrived yet. Okay, we will go to item 16, discussion and possible action on Midwifery Advisory Council appointments. Ms. Alameda.
Good morning. If you could turn to your packets, BRD 16-1. Effective June 30th, 2019, we will have 4 MAC member appointments that will expire, 1 licensed midwife position, 1 physician position, and 2 public member positions. The board staff went through the recruitment process, presented the applications to the MAC members at the March 7th meeting, and then the MAC members made recommendations to present to the board. For the midwife member position, the MAC voted to recommend reappointing Diane Holzer to the licensed midwife position. She has been licensed since 2005 and has served on the MAC since 2016 and is the current chair. So I would like to have a motion to reappoint Ms. Holzer to, sure.
I so move.
Can I get a second?
Okay. For the physician position, the MAC members voted to recommend reappointing Dr. Anne Marie I'm sorry, Carrie.
In this case, I think it's fine to do it as a slate.
Okay.
So we can
just
run through and then have a motion.
Oh, okay, sure. Good.
For all of them.
Okay. So reappoint Dr. Adam Marie Adams to the physician position. She's been involved with the midwifery community since residency and has served on the MAC since 2016. For the public member position, to reappoint Jocelyn Dugan, she has also been a midwifery advocate since 9 years ago from her home birth, and she has worked with several midwifery organizations over the years to increase awareness and access to care, and she has also served on the MAC since 2016. And then recommendation to appoint Danielle Abe to the public member position. Ms. Abe teaches 6 courses in the Allied Health Department at Sacramento City College and the executive director and leading faculty member for Childbirth Professional International, which is a training organization. Ms. Abe is a midwifery advocate, and her goal is to expand midwifery education. So if I can have a motion to...
Approve all
3.
I so move to approve all.
I think it's 4. 1, 2,
It's 4.
4.
Advisory, Midwifery Advisory Council's recommendation.
Okay. Are there any questions or comments from members? Any from those in the audience?
Yes. Hello, Hannah Rhee again. I just wanted to take this opportunity to submit another bit of information about the subject being the history of the African American midwife. The historical role of the African American midwife was one of hope and health, whose expertise helped define cultural perceptions of motherhood, protected, uplifted, and empowered women and men, and improved maternity care in communities across the nation. She was the keeper of tradition, a spiritual ritualist, and she played a large part in shaping cultural perceptions of motherhood, as well as functioning and officiating the rite of passage of becoming a mother. She carried valuable information passed on by predecessors across generations that positively impacted social health of the family structure and overall health of the community. And it's just a wonderful article about the role of the African American midwife. I'm deeply concerned. I greatly appreciate, of course, the Midwifery Advisory Council that you represent. But I am, we at Black Patients Matter are very concerned that your appointments and that your councils do not show a racial diversity. And so we just want to have, you all be aware of it, and I'm sure you are. And so I just want to submit this article for reading. Thank you.
Thank you. Are there any additional comments in the audience? Any comments on the phone?
No comments from the phone.
Okay. Ms. Cruz-Jones, can you call the roll?
Dr. Bolott.
Aye.
Ms. Friedman.
Yes.
Dr. Gonadev.
Aye.
Dr. Hawkins.
Yes.
Dr. Kraus.
Yes.
Ms. Lawson.
Yes.
Ms. Lubiano.
Yes.
Dr. Lewis.
Aye.
Ms. Sutton-Wills.
Yes.
Mr. Wormuth.
Yes.
Dr. Yip.
Yes.
And Ms. Pines.
Yes. Moving to agenda item 17, presentation on HIV and pre-exposure prophylaxis, known as PrEP, and an update on PrEP use for HIV prevention in California. Dr. Peters. Before Dr. Peters begins, I'd like to just briefly introduce him. In 2018, Dr. Peters was appointed as the medical officer for the California Department of Public Health's Office of AIDS. Please see his biography in the board packet materials.
Thank you, everybody, for this opportunity to talk to the board. This is really an honor to be able to present on this topic. I'm going to show some slides over on the left, or I guess your right, the audience's left side of the room. I have no financial disclosures to report. So in about 20 minutes, I'm going to try to review a number of aspects related to HIV pre-exposure prophylaxis. We're going to talk about the efficacy and safety of, or PrEP, the efficacy and safety of PrEP, recommendations regarding PrEP initiation and monitoring, novel PrEP agents that we expect will likely be in the field in the next few years, patient access and financial support that's currently available for PrEP, PrEP utilization in California and nationally, and some initial ideas regarding how PrEP can be further expanded. So for background, this figure shows the annual number of new HIV diagnoses in California from 2007 to 2017. And we have seen some decline in the number of new infections, but we still have close to 5,000 new diagnoses that are made per year. And this figure shows the rate of HIV infection among adults in California stratified by race and ethnicity. And as you can see, we have significant health equity and disparity issues related to HIV infection, especially among African American Californians, and that's true nationally as well. Regarding definitions, there are two closely related methods for HIV prophylaxis. One is called post-exposure prophylaxis, or PEP. This is a 28-day course, usually of 3 antiretroviral drugs, that helps prevent HIV acquisition after somebody has had an exposure. Pre-exposure prophylaxis, or PrEP, is when a daily oral fixed-dose combination of antiretroviral medications is used to reduce the risk of HIV acquisition over a longer term period, and that can be from months to years. The only current FDA-approved medication for PrEP is a once-daily pill that contains 2 antiretrovirals that are combined into the same pill. One of the antiretrovirals is tenofovir diproxyl fumarate, or TDF, and the other is emtricitabine. The brand name for this product, there's no generic that's currently on the market, is Truvada. It was approved for a PrEP indication in 2012. And actually, just yesterday it was announced that the generic version is going to come to the market in October of 2020. So one of kind of many things that are changing. So how well does it work? So this figure shows PrEP effectiveness in randomized controlled trials looking at 3 different patient populations. The dark blue in those populations are men who have sex with men, or MSM on the left, heterosexual people in the middle, and people who inject drugs on the right. And the dark blue bars are all the participants in those randomized clinical trials, and the effectiveness varied from 44% to 75% at preventing infection. When they subsetted the data for people that they could detect the medication in their bloodstream, the effectiveness increased into the 90% range. And among men who have sex with men, it's approximately 92% effective. Interestingly, and I don't know if this has been seen in other fields, but after the initial randomized controlled studies were done, a number of open label demonstration projects were done, and they showed a much higher effectiveness. And this table kind of summarizes those studies in a variety of different groups, but there's a very prominent study that's been done by Kaiser in Northern California, and they've had 0 HIV seroconversions among their entire PrEP patient panel. And so this figure summarizes that correlation among all the studies that have been done in PrEP, looking on the x-axis where you have adherence to PrEP medication. In the y-axis you have, in the y-axis you have PrEP effectiveness. In the x-axis you have PrEP adherence. And so as adherence is higher, effectiveness is higher, and it's almost a really straight line correlation. And so a number of the more recent studies that have been done, they're documenting levels of effectiveness approximately 90% or higher. So what does the clinical practice model look like for providing PrEP? So as of now, as there's only 1 medication that's approved for PrEP, it's a relatively straightforward process to evaluate patients for PrEP, to prescribe PrEP, and to monitor for PrEP. And the first step can actually, interestingly, be the most difficult, is identifying people for whom PrEP is indicated. So below, I've kind of listed 5 of the key populations. Surprisingly, what's really driven PrEP uptake so far has been people coming to their doctor and asking for PrEP, because there's a lot of direct consumer advertising to certain populations of people within California, but not to all people. But there are lots of indications, including if you have an HIV-positive partner, if you have sexual exposures, including anal sex, if you have bacterial sexually transmitted infections diagnosed, or if you are injecting drugs. The next step is then discussing what PrEP is, and some people already know, more than us sometimes when they're coming in, and other people don't know anything about PrEP. So it's kind of a wide variety of what a clinician needs to do to provide that information about what the benefits are and what the risks are. Once that has been done, there's baseline history, review of systems, and testing that is done, and I've highlighted some of the key test results. Obviously, they include HIV testing, and on there I have, in addition to the regular HIV test, sometimes we need to do an HIV RNA test just to make sure somebody doesn't have a very early or acute infection, because people are usually at quite high risk for new acquisition of HIV. But it also includes renal functioning, STI testing, pregnancy testing. The standard of care is increasingly becoming to initiate PrEP on the same day that you're evaluating somebody for PrEP, to basically take that momentum that the person has showed that they want to take this medication and to initiate it. Usually it starts with just a 30-day supply, and then kind of a check-in that's often done on the phone or even by text messaging, to see how people are doing, and then refills go from there. The monitoring, we'll talk about a little more, but there's usually an initial 30-day, not visit, but monitoring check-in to see how people are doing with side effects, if they're having any. And then after that, it's every 3 months. And the 3-month testing is important for HIV testing, because we don't want to give PrEP to anyone who already has HIV infection. But it's actually probably more important for sexually transmitted infection testing, because people on PrEP have a very low rate of HIV acquisition, but STIs still happen and need to be diagnosed. And then the final part is reassessing people for their ongoing need for PrEP. Just because a person has an indication for PrEP one day, you don't necessarily anticipate that they're going to need to be on PrEP for their entire life. So trying to stay on top of what the indications are and reevaluating. So I'm bouncing back a little bit, but to side effects. So the most common side effects are something that we call a startup syndrome. So within the first 30 days, people can develop, and up to about 20% of people can develop nausea. Sometimes there's headache, sort of diffuse symptoms. If it's more severe, people will have some vomiting. Those symptoms will usually resolve and go back to baseline in the clinical studies in about 3 months if people do have those symptoms. So that's why that 1 month check-in is so important, to see if, are you having any symptoms? Is it typical as to what we usually see? If it is, people benefit from counseling that it's going to get better if you are able to push through. The most significant side effect that we monitor for is renal toxicity. So we know the use of tenofovir in people who have HIV infection, that there's about a 1 in 1,000 rate of significant kidney toxicity. In the PrEP trials, that was not observed. They did not see any significant kidney toxicity, but 1 to 2% of people did have an increase in their creatinine, or an indicator that there was some renal compromise that was going on. In all of the cases that have been described, when people stop their PrEP medication, their kidney function returns to normal. But that's the reason why that is monitored for. The other toxicity that we have followed in clinical trials has been bone density. That's been another thing that's been looked at in the use of this medication in people with HIV infection. In the PrEP clinical trials, however, it was a very clinically insignificant impact on bone mineral density. So there's actually no indication to follow any bone mineral density unless there's another indication in people on PrEP. Another concern people, HIV doctors definitely had was, are we going to generate a lot of drug resistance? So we have not seen that. Usually if people become HIV infected on PrEP, it's because they're not taking medication. If they're taking medication, they do not become HIV infected. The biggest issue has been if we start PrEP on somebody who actually has acute HIV infection. That's been the situation. We've seen drug resistance, and that's why we include a recommendation to screen for acute infection before starting PrEP. I think the most controversial aspect of PrEP has been, what's the impact of PrEP on sexually transmitted infections? This has been a little controversial because STIs were going up quite rapidly before PrEP was really introduced, and before there were many people using PrEP, rates of STIs were going up quite significantly. But I think now there have been more careful looks at risk of STIs, and there is an increase in STIs among people who are taking PrEP, but there also is a lot more testing for STIs among people who are taking PrEP. So there might be more STIs that are happening, but there's more STIs that are being treated. And this analysis indicated that there was a net benefit because there are more STIs being treated than were happening. So where does that leave us? Risk benefit. The U.S. Preventative Services Task Force did a comprehensive assessment of PrEP as a prevention indication, and they put a draft recommendation giving it an A recommendation. So that's the highest recommendation that they can give and provide if that does get final approval, which we're anticipating hearing sometime over the summer, that potentially could expand access to PrEP significantly. I did want to just tell you that this is a really exciting field, so I just wanted to point out some new potential developments. There's a new oral medication called tenofovir alafenamide that was recently presented, and I have another slide on that later. There is also for women a vaginal ring product that has been developed, and its efficacy does not seem to be as good as oral PrEP, but it potentially is another option for women for protection against HIV infection, and that has been submitted to FDA. We're kind of waiting to see if they'll approve it or not. And finally, there is an injectable version of PrEP that is currently in a phase 3 trial where people get an injection every 2 months instead of having to take a daily pill. The other version of tenofovir, called tenofovir alafenamide, was recently presented at an international HIV conference. It was a non-inferiority trial, and it performed at least as well as the current version of PrEP. So that has been submitted to FDA, and we expect to hear probably later this year whether it'll be FDA approved as our second PrEP agent. Finally, there is a alternative PrEP is approved as a daily medication, but there is an alternative dosing strategy that's called on-demand PrEP or 211 PrEP. This is for people who have less, who can kind of predict when they're going to have their sexual exposures and have less frequent sexual exposures. So they might not really have an exposure to HIV except when they go to a particular type of event or venue. So this was initially a little controversial, but the clinical trial actually showed that this was at least as an effective strategy as daily PrEP. So it's being used quite extensively in California now, and a number of providers have protocols for this alternative dosing strategy. Access to PrEP is the big issue now, and although it is generally covered by insurance plans, including Medi-Cal, a lot of the people who need to be on PrEP are otherwise young people who don't necessarily have insurance or don't use their insurance if they do have it. In addition, there can be, even if you have insurance, significant copays. California in 2018 initiated the PrEP Assistance Program, and that basically provides wraparound financial assistance for people to take care of issues of copay or to provide more primary coverage for people who don't have insurance. This is an infographic talking about the PrEP Assistance Program, but it is essentially for California residents. It is, you qualify for it if your income is less than 500% of the federal poverty line. For an individual person, that would be about an income of $60,000. And there's two types of PrEP app. If you're uninsured, the PrEP app will enroll you in the manufacturer's assistance program, so you get the medication for free, and then the PrEP app program will pay your provider for their medical services and will pay for any additional testing and things that you need, like your STI testing or your renal function testing. And it reimburses at the Medicare rate, so it's a somewhat good reimbursement from the clinical side. The second type is for people who have insurance, but their copays are significant, and in this situation, it basically covers those copays. Because we have certainly heard of a lot of young people who were on PrEP, and they just couldn't handle the $20 copay every month. They went off, and they became HIV infected. So this is trying to deal with that difficult problem. And PrEP app is relatively new, and we're anticipating a lot of expansions to the PrEP program. I've listed a bunch here, but we are expanding into post-exposure prophylaxis as well. We are going to expand the age range down into adolescents, because PrEP is FDA approved for adolescents as well. And not listed here, but a relatively new program is we're introducing a telemedicine option for people who feel like there are a lot of people who need PrEP that feel like they just can't access the traditional medical system because of experiences they've had with the system. So this provides another way to access the medical system. The next topic is how well is PrEP being used, and this is national data. It's from the 20 largest cities in the United States. It includes data from 3 cities in California: San Francisco, LA, and San Diego. On the left, we're looking at PrEP awareness among different groups of people, and we're looking at differences in light pink from 2014 to dark pink in 2017. So we've seen in these cities at least almost universal awareness now of PrEP. In the blue is the use of PrEP. We've also seen increases in the use of PrEP, but this is broken down by race, ethnicity, and as I think all of you are aware, that rates of HIV infection have been highest among African American people in the United States, Hispanic, Latinx people in the United States, and the use of PrEP has been lower in those groups than in other race ethnic groups. Use of PrEP in California, our goal is that we're monitoring this using prescription claims data. Our goal is that by 2021, We want 60,000 people using PrEP within California. We estimate that that would be about 50% of the people who need to be on PrEP within California. So we have seen from 2015 to 2017 an increase in PrEP, but we're not on the trajectory to get us to where we need to be. So I think we're kind of at this point where the people who are really advocating for PrEP and really wanted to be on PrEP, they're on it, and now we kind of need to bring everybody else along, people who are not quite as aware of their risk or maybe are not as enthusiastic about taking a daily medication. And we're seeing a lot of, as we have seen a lot of racial, ethnic disparities in HIV infections, we're seeing a lot of racial, ethnic disparities in people who are using PrEP. So we estimate that 44% of the people nationally who need to be using, who should be on PrEP, are African American, and only 1% of people in the U.S. using PrEP are African American. Likewise, people who are Hispanic, Latinx, we estimate about 25%, and nationally only about 3% of people using PrEP are Latinx. So we are, what we're seeing is that we've seen this big increase predominantly in white men using PrEP, and we need to expand to women, we need to expand to other racial and ethnic groups. One issue with PrEP is it kind of depends on where you live. So in the Central Valley, which is on the left, where we see predominantly Latino MSM HIV infections, we have very few providers of PrEP. And this is an area where there's really thousands of people who need to be on PrEP, and there's only a handful of providers. Most of these providers are also in private practice and only take certain types of insurance. On the right is in Southern California, and in Los Angeles has really embraced PrEP and has a really extensive network of providers. If you leave sort of the core Los Angeles area, though, even in that area, it's a little sparse for the number of people that are living in that area. So how can we expand PrEP? There's a lot happening. I think I'll just kind of say that this slide tries to summarize a lot of what is going on. I will say we do benefit in many ways from the consumer education that is going on. The drug companies, for obvious reasons, are really doing a lot of advertising, but there's a lot of community-based organizations that are as well. There are a lot of PrEP detailing opportunities that the health department does, in that our AIDS education training centers do. So for clinicians that want to kind of get up to speed quickly, there's one-on-one mentoring and education available. The health department is also kind of doing warm handoffs to providers who have PrEP. So if we have a syphilis case that's diagnosed and the person is HIV negative, we try to do a warm handoff into a PrEP situation. And the problem, though, is when you don't have the provider that you can do the warm handoff to. The telemedicine option, I think, is might be helpful, and physician education, I think, is always important, because this is a relatively new field of medicine that was not really emphasized in medical education when most people did their medical education and then did their residency. This is outpatient, and most people sort of train in more inpatient settings. So we are so appreciative to the medical board for allowing us to disseminate the Dear Colleague letter to physicians. We got a lot of positive feedback from people writing back that they were really happy to see this coming out. We are kind of thinking, we kind of recognize that the board is very important for physician education, and are kind of thinking, what are other avenues? One is, are there opportunities with continuing medical education? There are 4 states in the United States that require, at some point in people's licensing career, that they do an HIV-related CME activity. One state that does that is Florida, and I think there are, as somebody who has lived in the Southeast a lot, there are quite a lot of similarities between the HIV epidemic in Florida and what we experience in California, where you have a lot of disparities in access to care. So that potentially is a model for something, if there is interest among the board to look into that. Again, right now this is a fairly straightforward indication. I think you've sort of seen that with the pharmacy bill. There's a lot of pharmacists that are interested in doing this. I think this is a great opportunity also for nurse practitioners and physician assistants. So I think there's really a lot of opportunities for physician leadership. If they're for doctors who are just so busy with their own practice, they can support additional clinicians to help implement these programs. And I'll stop there and just wanted to acknowledge thank you for your time.
Thank you. That was very educational, very informative, and I was really appreciative of you talking about the disparity issues, but also clarifying how those disparity issues are happening, because I was going to have several questions around that. So thank you for addressing that, bringing it up, and then also addressing that. I'd like to see if any of the members have any comments or questions. Dr. Hawkins?
Dr. Peters, thank you very much for coming before us. And you recognize how important education is, not just for physicians, but consumers. As you know, consumers actually run with things, given the information, and sometimes they create best ways of actually getting out the information. One of the biggest problems, as you indicated, is that in the African American community, not only just with men have sex with men, but men have sex with women, and certain high-risk female exposures as well. I'm curious, though, has there been enough time to see what the impact of that mandated CME education results in Florida or other places? Do we know how effective it was in moving the needle for any parameter to look at?
That's a great question. I don't have metrics, but I think one actual interesting outcome in Florida is that they have a very extensive state-based PrEP program where all of their state-run sexually transmitted infection clinics are providing PrEP free of cost to people. And there could be a variety of reasons as to why that happened, but I really believe that because every physician in Florida has had that HIV CME. They usually do it at kind of these big events where they're, they got to re-up for their internal medicine board exam, and so there'll be an hour lecture on CME that's part of that review course that counts towards their licensure. And if you look at other southern states where they don't have this CME program, there aren't those progressive programs for how to address the HIV epidemic. And I just have to believe that it's really because it's usually physician leadership that's really demanding that those things happen. The grassroots organizations have been advocating it for such a long time, and so for me that's sort of an indicator that it is having a benefit there, that they've kind of embraced this program in a part of the country where there have not been a lot of programs like that.
Dr. Lewis?
That was a very good presentation. One of the best I've heard in a long time.
Right, where you stay awake.
For this group. I live in Palm Springs, which it's a party like every weekend. And so I want to go back to PEP, because that's the biggest need for certain cities and certain venues. And we were discussing this yesterday about pharmacists being able to give a course of treatment, et cetera. How can we deal with the handoff to a provider if some of these people don't live in their, don't live in the area that they need to receive that medication? Because once they go home, it's like, oh, okay, well, I'm done, right?
Yeah.
So what have you thought about?
I think, just to clarify, I can't comment on any existing legislation, but sort of that general, I think you're asking like that general question, the handoff,
Yes.
and it is, and I think it does get to that issue of we don't want the perfect to be the enemy of good. where it would be ideal if we had a system that was in place so that there are so many providers and if there was, so I may be thinking of, I'm just going to take it to the example that somebody was recently diagnosed with syphilis. And we've diagnosed this person with syphilis multiple times and treated, and we know that people who have been diagnosed with syphilis have a really high rate of HIV acquisition, that it's a canary in the coal mine marker. So we need to create that situation that I think doctors respond to demand. So doctors want to be helpful. So if they have people that are being referred to them, especially if it's coming from another clinician and they need follow-up, I personally believe that that'll happen. And it's not like such a complicated intervention that we're not asking people to do difficult neurological exams and things. It's really quite straightforward that if people are managing hypertension, they're managing pre-diabetes. This is less complicated than doing that. So I think the doctors are there, but and people who need to be on PrEP are there. I think we do need to increase that demand, and that is I think going to increase the demand.
Right. Thank you.
Okay. Mr. Mormouth and then Dr. Yip.
As a more or less middle-class gay man, I think I probably represent a group that is already beating down your door to get PrEP. And I think we've moved beyond that to try to get underserved communities to also get onto PrEP so that we don't have to deal with the long-term effects, because one way or another, we hope to stop the transmission of AIDS, HIV/AIDS. My question basically, you did a wonderful job of breaking it down by ethnicity, race, various things, but do you have any data on specific groups that you mentioned that might have other reasons for lack of trust with the doctor, like trans women of color, immigrants, just generally groups that have reason to fear interacting with a medical doctor?
I think yes. Let me clarify your question. Is it reasons? Why do we have an understanding of why? What are reasons that people are not able to access PrEP?
Well, yeah, I guess I understand that you can't comment on legislation, but my concern is that by dealing only with PEP rather than PEP and PrEP, we're still leaving behind some very key communities that would be better served if they have an easier access to PrEP. And so I would like to know if what is the current rate of adoption, if you know it, and if you have any ideas, not in current legislation, to improve that.
Yes, yeah. I think the barriers are very significant, and they're not simple, and they really run the gamut. From depends who you're exactly who you're talking about, but there are issues of violence, there are legal issues, there are issues of racism. There are issues of medical mistrust. So taking a pill every single day for, depending on your cultural background, that can be something that you feel very comfortable with, or that can be something that you feel like somebody might be trying to trick you. And also, though, even with all that, there are, with all the barriers that people do have to access PrEP, there are just countless stories of people who go to their doctor and ask for PrEP and are told, I don't do that, or, condoms are very effective, you should really be using condoms, or not doing whatever it is you're doing that's putting you at risk for HIV. So even with all the barriers, there are people who are asking for it, and I think we really need to address all of those issues. So we do have really wonderful community partners that are working at the grassroots level, and we have from the other side, I think, really here trying to work with clinicians to really, one, just show why this is such an important service to offer within your community, and really how many people really need this service that are not on this service. I think the reason why it's been so successful among gay white men is that there was really a pent-up demand for this product, and then when it was available, people really demanded it from their doctors. And you could imagine if you were working in a certain location and you were not providing PrEP as a primary care provider, you could imagine what your online reviews would look like. So there was a lot of consumer pressure, and then sometimes that's when people were like, oh yeah, why is everyone asking for this? I'm going to review the literature and make sure I'm offering it. But I think you're right that it's not so simple just that we, even if we were offering it to everybody, there are going to be lots of situations where people are not trusting us as physicians, or not coming to us as physicians, and so we need to think of a multi-pronged approach. This is not a solution to everything, but I think you mentioned trans women, women who have a lot of issues with domestic violence. Telemedicine as a PrEP option might be a good way of doing that, because you can really you control the encounter with the clinician a lot more than if you have to walk into an environment and interact with multiple people who maybe the doctor has kind of trained his frontline staff, but the people who are at the beginning of the clinic have not been trained, or you're not comfortable sitting in the waiting room. So I think we need to be creative, and I think Dr. Hawkins, you also mentioned in the African American community, and definitely African American women, I think, are a key population to that we need to work with, because we have so few women that are taking PrEP right now. It can be really difficult to determine who is going to benefit the most from PrEP among women. It's not kind of as clear cut as when you look at people who are injecting drugs, or men who are having sex with men. But I think that work with African American women, and there are a lot of people that are doing that work in California, has two benefits. It benefits the individual, but usually those individuals then disseminate the information to their social networks. And so you've kind of educated one person who's then educated 5 to 6 other people who are going to trust them more than really anybody else that's going to talk to them.
Dr. Yip, do you still have a comment?
Yeah, thanks a lot for the education. I think CM is a very good idea. As I can see, on the primary care physician, there's still ignorance and fear about taking care of AIDS patients just because they don't know what to do with that. So I think that's a very good suggestion. I'm looking at the implementation point of view as far as like county health, the state health. It may be a good idea in the future that a website or app, even publication, metro states, etc., that can identify area that people can easily go to for treatment as part of the campaigns to increase access, weekends, evenings. And you'll be surprised a lot of CVS don't even open at evening for medication. Some of the pharmacy may not even stock those medication. So the urgent care open all the time, that can be a site for the consumer needs that. And also physician, I think primary care, if they get educated on that, can be another wider network of physicians who can provide those services for the patient needed too. Thanks.
Thank you. Ms. Lubiano? Oh, you
too. Thank you, Dr. Peters, for all of the information. A few questions that I had. One, for patients that are taking the medication, do we have an idea of the average duration that they're on once they start, and about how long do they stay on it?
Yes, I would say it's very variable. So there is a significant drop off over the first 6 months or so. I would say one issue is that there's not a great way to monitor it, and people, although the initial recommendation was to use PrEP every day, so we thought we could just monitor refills every month, but now we're seeing that as many as 40 or 50% of people are kind of coming on and off of PrEP, and sometimes that can be completely appropriate. So it's very hard to see in the data if somebody is using it very appropriately, that they are only in a monogamous relationship for a period of time, and there's really no reason to be on PrEP, and then they leave that relationship, and then they would start back on PrEP. So I would say yes, it's very different than HIV treatment, where most people once they're on treatment, they stay on it, and people do drop out, but it's really the goal just to be on treatment for the rest of your life. This can be much more sporadic. So I think our hope is that it is really important for people, even if people stop taking PrEP, if they've had that experience on PrEP, it's a very non-toxic drug that usually people kind of take it and they really are having no issues with it. So if they have that positive experience with it, then if they continue to be even if they stop, if they continue to be at risk for HIV infection, it's going to be a much lower barrier to get back on it the next time somebody suggests it.
Got it. Thank you. And the second question I had was related to your slide about the different outreach efforts different ways that we're getting the information out. So on a practical level, now that for myself that I've heard the information, and how can I go back to my community, especially you mentioned grassroots efforts and that kind of outreach. What could I do to get that information out? Is there a liaison with your department that I can hook up the people in my community with your department, or what is your guidance on that?
Yeah, definitely. Anyone can reach out to me, and we have. I think we're really lucky in California that I didn't mention this in the presentation, but the very first clinical trial done to establish the effectiveness of PrEP was done by Dr. Grant, who is in San Francisco. In the most recent presentation about this newer medication for PrEP was done by Dr. Hare, who is also a physician in San Francisco and Kaiser. So we have such a rich, we really have a wealth of resources in California. So within the Office of AIDS, we have a dedicated PrEP specialist, who is also our transgender health specialist, and it really is in tune with grassroots activities with communities. Has worked in the Oakland area on transgender health for many, many years. But in addition, every local health department also has PrEP activities, and so we kind of have a statewide effort as well as local community efforts. And in many of the PrEP activities that are funded through the state have happened because of grassroots advocacy for it. So I think, as you can imagine, government is not the most nimble at doing things, and it's really been our community kind of demanding that things happen has sort of led to that legislation and led to it happen. So it's really for us, that's how we find out about what's working, what's not working. So we definitely encourage anyone to reach out to us.
Thank you, will do.
Dr. Bolott?
Hi, thank you very much, Dr. Peters. I wanted to just ask you some very straightforward questions. On the 12 to 17-year-olds, is that under Title IX under Family Pact, or is that going to be accessed through, let's say, a public health department for treatment of that age group?
Yeah, my understanding is that Family Pack would not cover that, so it would be accessed through the PrEP app program.
Okay.
It would be covered by people's. If somebody was in a situation where their parents they could get their parents' insurance to cover it, it would be covered by their parents' insurance. But usually the people who want to access PrEP don't want it to be on their parents' insurance. So with that, there's going to be like an attestation that you can't even if you have insurance, you can't access that for your PrEP. And so the PrEP app program would cover the medication.
I see. It would be great if they did have that for the Family Pack. That would be wonderful. And in terms of the federally qualified health centers, do you have a read or a data set that shows the number of FQHCs that actually provide PEP and PrEP? And I ask that simply because, to Dr. Yip's point, oftentimes this is a large group of practicing healthcare teams, PAs, NPs, and physicians. But one thing that I believe is not 100% for every FQHC, but the routine health maintenance things are taken care of very well. But when you start to add on additional specific programs, it becomes challenging. And I say that coming from a family medicine residency training program where we have really bright young kids and they're doing a terrific job. And some of the areas that people are fearful of is, oh gosh, do I or don't I get that HIV RNA? Well, let me see what it means, or how long is it going to be? So one of the things that I'll just comment on in the training, LA County Department of Public Health does an amazing job, but the area of the science behind this as opposed to the how to dispense, I think there's a gap on the science. So I think that would be one thing to really focus a little bit more on. So thank you for an excellent presentation.
Are there any additional questions or comments? Thank you, Dr. Peters. We really appreciate it. Okay. Oh, you can return back to your seat if you're okay.
Okay.
Yes, I'm going to get to you. Okay. Public comments.
Yes, I apologize. So Dr. Peters, hello. We've never met before, but I'm Hannah Ree, Dr. Ree. And I'm the co-founder of what's called Black Patients Matter. And it turns out that we are the largest and fastest growing Black health network in the state of California on Facebook. We now reach over 20,000 patients. At least 20,000 individuals in the state and probably beyond. So, thinking about your outstanding presentation, so informative. You're absolutely right. As far as all the, the brain power, the resources, the energy that's been put into the utilization of PrEP, and then acknowledging that there is still a racial disparity. It could be the answer is right next to you. So if someone maybe from your organization, we will definitely reach out to you as well, wants to just message us on Facebook like the rest of the world, I suppose. We will definitely utilize our space to reach out. It does seem that perhaps whatever algorithm or posts or style or cultural approach that we're utilizing is touching folks. It's touching folks. And so I want to reach out with you about that. And then also maybe to point out that it's kind of interesting, at least in Southern California, that the map that you showed, which represented the utilization of PrEP in certain areas, certainly in Los Angeles County, myself being a member of the Los Angeles County Medical Association, it's interesting to me that at least to me, that the map actually correlates pretty well with the number of African American physicians and the utilization of PrEP. So I do wonder if perhaps thinking out loud that this kind of cultural gap, that's still, whatever is existing, whatever gap is existing, to maintain a racial disparity in utilization of PrEP, it could be that, as other published articles have shown, that the utilization of African American patients seeing black doctors could be the answer. So we're here for you. Thank you. Thank you, board.
Are there any other comments from the audience? Any comments on the phone?
We do have a comment coming from Dr. Lang, President of the Golden State Medical Association. Your line is open.
Thank you. Yes, I would like to thank Dr. Peters for the excellent presentation that he gave. As a practicing family physician in an inner-city practice for over 30 years, I find that with certain cultures, specifically the African-American and Latino cultures, much of which was referred to by a previous speaker, but it does take a much more intense and hand-holding approach to get black patients to use PrEP. It's often also difficult to find pharmacies in our communities that are able to fill the prescription even once you're able to get it to the patient. For these reasons, I think that one option that we should be looking at is covering PrEP therapy by Medicare or mandating insurances to do so at Medicare rates, in much the same way that dialysis is now covered by Medicare for everybody. This would likely increase the amount of physician involvement rate, and it would allow people to work on explaining to patients the way it needs to be done. Building trust with the patient population that is often distrustful of the medical community and often with good historical and current reason does take much more time and effort than managing hypertension. And I will say that's not so simple a task in treating African American populations. I think we need to realize that in America, trying to tell anyone about how to conduct their sex life is challenging, and our medical words are frequently ignored among the general population, quote unquote. When you speak on the topic of sex with minority populations, whether it's of ethnicity, gender, or sexual orientation, you must first establish a real sense of trust with those patients before they'll even often openly disclose to us what their risk factors are, so a physician can offer this therapy to the at-risk patients and begin that conversation. So I would like to encourage you, Dr. Peters, to work more to get the eligibility out so that African American patients and Latino patients who are ranging so high in the statistics but so low in and actually get treated. And on the issue of education on the topic, the Charles R. Drew Medical Society of Los Angeles has had at least 3 lectures in the past year and a half on PrEP and how to use it. So we, as an African American Medical Association, are trying to get the word out. We're educating our physicians, but everybody is not a member of our organizations and therefore don't get that education.
Are there any other comments on the phone?
No further comments on the phone at this time.
Okay, great. Thank you again. We're going to go to agenda item 15, a presentation on the waiver for physicians to prescribe or dispense buprenorphine. Would Dr. Henry please come forward? Before he begins, I'd like to introduce Dr. Henry. Dr. Henry is a general internist and associate professor at the University of California, Davis. For information on Dr. Henry, you can look in the biography of our board packet. Dr. Henry.
Thank you very much. I apologize for being late to the meeting. So the purpose of, I have sort of two purposes for this talk. The first part, I will talk a little bit about the background of buprenorphine, the medication. This is not meant to be a pharmacology lecture, but just some background. And then the second part will talk about the regulatory process related to obtaining what's called a 2000 data waiver, which is the federal, which is also called the X license. That's the federal amendment to the DEA license that allows physicians to prescribe Schedule 2 or 3 medications for substance use disorder, particularly opioid use disorder. Those are my disclosures. So buprenorphine is an opioid medication. It's a mu receptor agonist like all opioids. The main difference with this medication is that it's what's called a partial agonist. And so the best way, as a general internist and primary care physician, I think of it as it's a key that fits into the lock, but sort of turns the lock only halfway and then kind of gets stuck. So the interesting thing about buprenorphine is that once it is in the mu receptor in the body, it tends to bind there sort of halfway, and then it sticks there and prevents other molecules from other opioids, like morphine, from binding. So that's the unique sort of pharmacological property of it. It has some other pharmacological properties, and it has two main clinical uses, one for pain and one for treatment of opioid use disorder. The preparations for buprenorphine, there's different ones depending on the use. The formulations that treat opioid use disorder primarily or that are FDA approved for opioid use disorder treatment are typically sublingual. The most common one would be Suboxone, and that has a mixture of buprenorphine and naloxone. That's an abuse-determined formulation, so that if you take it sublingually as indicated, the naloxone is not absorbed, but if you try to inject it, then the naloxone will counteract and prevent euphoria. Those are the formulations that are primarily used for pain. There's a patch called Butrans, and there's a subbuccal patch called Belbuca. So just so you know, the key sort of reason that buprenorphine is used as a treatment or has become is able to treat opioid use disorder is that it is unique in that it has a ceiling effect in respiratory depression side effects. So most opioids, as you know, one of the main side effects that's most dangerous is decreased breathing, decreased drive for breathing. And the more medication you take, the stronger that effect on the breathing becomes. And it's linked tightly to the pain control. Buprenorphine is unusual in that as you take more and more of it, you get more and more pain management or pain effect, but the respiratory depression effect levels off about halfway because, again, it's a molecule that only sort of sticks halfway into the mu receptor. And so that's a very unique property of buprenorphine that is unlike other opioids. So there is a potential it's not a completely safe medication. It can be abused, buprenorphine, but it is, because of the respiratory depression, it's much safer than other opioids, and the risk of overdose is much, much less. It also has a fairly long half-life that makes it suitable for treating opioid use disorder. In your packet, there's some information about different aspects of buprenorphine for pain. I will say that it has been around a long time as an IV medication that anesthesiologists use in the hospital. And it is also commonly used for cancer pain treatment in terms of the patches. It is sometimes used for chronic non-cancer pain, but not as often. The main advantages, some of those advantages are sort of more for the ones of you that are anesthesiologists and pharmacologists. The main ones that are clinically important is it has, number 8, the ceiling effect on respiratory depression. And particularly, it has a lot fewer side effects and a lot better safety profile than many other opioids, particularly methadone. So it doesn't have the QTC prolongation or the effect of potential cardiac side effects that comes with methadone. It does not have the hypogonadism that comes often with methadone or some of the side effects. It doesn't have as much withdrawal. So it's considered safer, particularly compared to methadone, which is the other medication that, as you know, is commonly used for treating opioid use disorder. And so that is just a primer on buprenorphine. In the next part, I will talk about buprenorphine for the rest of this talk in the context of treating opioid use disorder. And in 2000, the federal government passed what's called the Data Waiver Act. You probably are aware of that. It's often termed the X license or the XDEA. So it is a special waiver that allows physicians to use treatment, use Schedule 2 or 3 medications to treat opioid use disorder in the office setting. So one of the main sort of practical benefits of buprenorphine is that it can be dispensed at by a Walgreens, and it can be prescribed in a clinic. In contrast, methadone for treating opioid use disorder can only be dispensed from federally licensed methadone clinics. So it's very restrictive. In some cases, there's considered a stigma. People don't like to let people know that they're going to the methadone clinic to get their medication. So one of the main sort of federal responses to the opioid crisis and the rise of opioid overdose deaths has been a push at the federal level to increase the capacity of prescribing buprenorphine for opioid use disorder. And there's been a lot of funding from SAMHSA, from CDC, from HRSA, all the standard federal agencies. Just in terms of evidence, a lot of the original evidence came from France, where there's not there's no special license required there to use buprenorphine for treatment of heroin or opioid use disorder. And the evidence in that country, really, the use of buprenorphine dramatically decreased deaths from opioid overdose. In the United States, in order to treat with MAT, medication-assisted treatment, in an outpatient office setting, a physician needs what's called the data waiver, and that's named after the 2000 law. The most common way this is done in the U.S. is an 8-hour training for physicians. There is a training now for nurse practitioners and PAs, I believe, but that's a different training. I think it's 24-hour training. But for physicians, there's an 8-hour training course, at least half of which has to be sort of in real time. You take the course, and then you send off something to SAMHSA DEA, and you get your X license. And that training involves sort of basics of pharmacology, like you just saw, and the basics of treating substance use disorder, particularly buprenorphine. But the fact that you have to do this special training is a major, major barrier to physicians using buprenorphine in their practice. It's not the only barrier. There's other barriers, but it is a major barrier, and it's one that's particularly relevant to the medical board. And in California, there was a study by the Urban Institute in 2016 that estimated that approximately 200,000 Californians who do have opioid use disorder lack access to local treatment via buprenorphine or methadone. So there is clearly a great need, and the need for treatment of opioid use disorder is much greater in California than the current sort of bandwidth to treat. And the bandwidth includes methadone clinics and outpatient treatment of using buprenorphine. So those are the two main ways that you can be treated. You could, you can also go into an inpatient detox facility, but that's, very, very rare, very unusual. It's primarily methadone from methadone clinics and buprenorphine prescribed in office settings. So the U.S. Federal Code provides 8 pathways to obtain a Data 2000 waiver or an X license. I've provided them in the slides mostly for your, just for your reference. So for example, if you are certified in addiction medicine or addiction psychiatry, you automatically are certified to prescribe buprenorphine. You don't need that extra training. Pathway 4 is the most common way, which I talked about. This is the standard 8-hour waiver training, and it's offered by these different agencies that are named in the federal legislation. For example, I think I took mine from the American Osteopathic Addiction Association when I got my license. But there is this pathway 6, which is why what I wanted to bring to your attention today. Oops. So the federal code allows that a physician can prescribe buprenorphine for opioid use disorder if that physician has such training or experience as the state medical licensing board of the state in which the physician is providing treatment considers to demonstrate the ability of the physician to treat and manage opioid-dependent patients. So the components of the training are spelled out in the federal code, but this is a specific pathway that is different than the standard 8-hour training. These are the last two. So a couple of states have worked with their medical boards to use Pathway 6 to increase the number of physicians in those states that are licensed to prescribe buprenorphine and try to remove that waiver barrier as one step towards increasing the capacity of opioid use disorder treatment in their state. So the first state to do this was Rhode Island, and I gave a paper about that process in your materials. Rhode Island has the benefit of having only one medical school, and so it's very straightforward. Everyone in Rhode Island graduated from there, but they worked with their board. They certified. They went through their curriculum of Brown Medical School, and satisfied themselves and made sure that the medical school did that it met all the federal requirements for a waiver. And then they presented this information to the Rhode Island Medical Board, and who then actually created a sort of educational transitional license similar to what's going to happen here in a couple of years in California, so that residents, medical students who graduated from Brown University and then went on to do residency in Rhode Island were able to prescribe buprenorphine to their patients on day 1 of residency. And this, I believe this initiative was really driven by the medical students largely because they saw the need. It was on the East Coast. There's lots of more heroin deaths historically than on the West Coast, and the medical students really drove this desire, saying we need this training. Arizona is the other state, second state that's pursued this pathway. They got 6 of their schools together and wrote a voluntary statewide curriculum on pain and addiction that covered all the required elements of Pathway 6. And then they have been working with the Arizona Medical Board to say that any state medical school or NPDO school that adopts this curriculum would meet the Medical Board of Arizona would, then deem that school graduates of that school to be eligible to prescribe buprenorphine for opioid use disorder. They are in the final stages. The board actually determined that they wanted a legislative change to specifically allow to say that the state medical board has the ability to do what the federal law said that the state medical board had the ability to do. And at last I heard they were hoping that would pass like this week or any time. So graduating students and making them automatically eligible for waiver is really a game changer because, like I said, it eliminates this key barrier to prescribing buprenorphine for opioid use disorder and treating patients who have opioid addiction. It could increase the number of persons prescribing and interested in MAT, which is the general term, medication-assisted treatment. It helps destigmatize the diagnosis if it's a routine thing that is taught in medical schools, not just sort of you learn about it in San Francisco General, and it's considered a stigmatized condition, addiction, and things like that. It can entice medical schools to use curriculum, make sure their curriculum meet all these federal standards, and they are giving better training to their graduates about substance use disorder generally. The limitations of this Pathway 6, it only works for trainees who stay in California. If it were adopted by the medical board in some way, that ability to prescribe buprenorphine only continues if the graduate stays in residency and practices in California. But in California, something like 2/3 of the med students and residents stay in the state, so it's a large proportion. And I'm here today on sort of behalf of the University of California Opioid Curriculum Work Group. This is how this presentation came about. This was formed in 2018 by the Office of the President and has representatives from all 5 UC medical systems. And it was tasked with formulating a shared curriculum across all the UC med schools on opioids, pain, and substance use. And we are actually recommending, as one of our official recommendations, that all graduates of UC medical schools and residency programs receive training that satisfies the federal requirements for obtaining a data waiver. So saying that we want all the UC medical schools to have a curriculum that meets the federal standards, regardless of whether or not they actually get a federal waiver, but we want all that information in the medical school curriculum. They're working on adding an opioid-related case into the required exam that fourth-year med students have to take. And particularly for this group, we've created a set of competencies now that have been endorsed by the deans of all 5 of the medical schools. They are competencies that are designed to guide the curriculum of the different UC medical schools. They have components related to pain management, substance use disorder treatment, and public health related to the opioid crisis. And we extensively reviewed the literature. We had other competencies, other frameworks that we borrowed. For example, the Arizona curriculum that they created is really just a set of competencies. They just called it a curriculum because there was some medical schools that didn't like the term competency. So we used the existing literature, and they're pretty detailed actually, but we think that clearly if a med school curriculum met all those competencies, all those requirements, then it would more than meet the federal requirements for a data waiver to prescribe buprenorphine and treat opioid use disorder. And that's what I just said there. If the medical board certified that a school's curriculum met the requirements for Pathway 6 data waiver certification, then students would automatically be able to get a data waiver if they pursued residency in California. That's sort of what I said previously. I've already mentioned some of this. Rhode Island created an educational license category to meet this requirement, and I think that the new California educational license process could potentially allow for a similar system here in California. And I think in closing, I would like to urge on behalf of the UC opioid curriculum group for the board to consider doing as much as it can, or really strongly consider and try to find a way to sort of use this Pathway 6 in the Federal Register to increase the number of physicians in California who are licensed to treat opioid use disorder, and therefore help remove a major barrier and increase capacity to deal with the opioid epidemic. I think this type of regulatory action is really right in line with the mission of the Medical Board of California, particularly around promoting access to quality medical care through licensing and regulatory functions. And that's my comments, and I'm happy to take questions.
Dr. Henry, we appreciate it. Ms. Freeman? Yes.
Thank you very, very much. That was a wonderful presentation. Thank you. It seems like it's a magic pill. And I'm wondering who manufactures it, because it's clearly not the Sackler family's pharmaceutical group.
Yeah. I don't know off the top of my head which companies manufacture it. I know there are some companies that have looked into getting fancy new, there's like an implantable version. There's definitely companies looking for fancy new versions to market. I don't know who manufactures, particularly the companies. It is a fairly remarkable pill. It does have some, risks. There is a risk of abuse. It can be abused. There is a risk of overdose. It's not, but it's much, much less than with other opioids like fentanyl and things like that.
Is it on the street?
I think it can be abused. It has been abused, and I don't know the details, but or the statistics around it. But there is a sort of street value to it. Mm-hmm. But it's much, much less than like an oxycodone or a morphine, and it is the versions that are prescribed for opioid use disorder are typically they have naloxone mixed into them. So if you try to inject them or skin pop them, it doesn't give you a euphoria. So those are the formulations that are typically used for opioid use disorder. So I hope that answers your question.
Okay, Dr. Bullitt, then Dr. Kraus, then Dr. Gananadev.
Thank you very much. Excellent presentation. Couple of thoughts and I applaud the work that's being done with your group and UCOP and others around the country. The one challenge, of course, is it's going to be 7 years maybe before that person is going to be in a position, or maybe at least 4, to go from medical school to be able to prescribe. The urgent need right now for individuals is that when you have a patient inpatient in hospital, where's the doctor who has an X waiver? Secondly, so they're in an acute hospital. Mm-hmm. Now you're going to transfer the patient from an acute hospital to an acute rehab. There's no doctor that has an X waiver. We're going to put them in a skilled nursing facility. Some very reputable, large names. Can't get them in there because we don't have doctors with X waivers. So it's been 20 years, and we prescribe a heck of a lot more dangerous drugs than buprenorphine. Mm-hmm. And the fact that we have to stigmatize it, hide it behind an X waiver is really concerning to me. And I hope that, since 20 years have passed, we could come up with a even better plan. Again, I think this is a great thing to be able to do this. But if we are going to destigmatize, then this should be no different than me prescribing warfarin, losartan, or any other drug. And, people have been prescribing opiates. Mm-hmm. Right? And that's the opioid epidemic. Now we're going to try to do something to help people, and we have barriers. So I would say that that's going to be something that I hope that people will take up that issue and really think through the X waiver and its need, and how can we make this barrier a little bit easier. Yeah. So those are just my comments, but I applaud your work. It's really excellent.
Thank you.
Dr. Kraus?
I agree with all of Dr. Bullitt's comments. It puzzles me as to why there are these regulations restricting access. There are hundreds, if not thousands, of new drugs each year, and physicians should be educated about them, but there is no federal or state requirement to have specific education to prescribe a new drug. And as stated by Dr. Bullitt, this is far safer than the oxycodone that I'm authorized to prescribe at will today. So I think that the medical board should assist in all ways possible to make this more available through legislative advocacy and by whatever means we have the authority to do so. But obviously it also calls for our soliciting federal action. Thank you very much.
Okay.
Thank you. Dr. Gananadev?
Dr. Henry, excellent presentation. So this UCOP you have in the curriculum work group, but remember there are four other MD schools in California and 2 DO schools. Mm-hmm. So what are you doing with them? Are you contacting them? I'm the president of one of the universities, California University of Science and Medicine, which is a new school. So I'm just curious how you're disseminating to all the schools in California.
Yeah, so that's a very good question. We just finalized the these recommendations last month. So we just got them sort of, we started with University of California, and there are a few things like the required sort of standardized patient exam. I think Stanford, some of the other med schools participate in that. But this is not meant to be exclusive, and we would, speaking on behalf of the other people in the committee, we would love for all, if this is something that that can assist the UC schools in terms of getting their students waivered for buprenorphine prescribing, then there's no reason that the other schools couldn't use the same curriculum. It's sort of the thought. So I guess we're still disseminating within UC. We haven't started to other medical schools. We are planning to write it up and publish it. And then the other part is if the set of competencies were deemed by the board to be sufficient for meeting the federal code pathway 6, then I think that would really make it easy for other schools to pave the way to have those same benefits for their graduates, rather than have to reinvent the wheel for every, California North State and Loma Linda and Turo and all that.
Dr. Yip?
Thanks for the presentation. I kind of missed, what does MAT stand for?
I'm sorry, I realized that in the slides. It's medication-assisted treatment. It's a shorthand for treating with opioid, methadone, and buprenorphine. And again, I don't know why we use that term for substance use treatment and not for, we don't call diabetes treatment medication-assisted diabetes treatment. And again, I totally agree with the comments that it doesn't make a lot of sense that there's an waiver, that there's a special regulation for the treatment for opioid use disorder, but not for actually prescribing the opioids that can often cause the problems. But I think the concerns at the federal level historically have been along the lines I think Ms. Friedman alluded to. There is an abuse potential, and many people have been historically concerned about physicians prescribing medications for, to sort of promulgate drug abuse.
Dr. Gananadu?
Yeah, just to follow up on that, what I asked you, if all the schools in California follow, including the DO schools, it makes for the medical board and the osteopathic medical board to go to the legislature and have the appropriate things done. So that's why it's extremely important to get all the schools involved rather than only UC schools.
Yes, I think I totally agree, and I will bring that back. My understanding is I'm not sure whether their legislation is needed for the medical board. That's something for the medical board and the lawyers to decide.
So we don't believe right now that we would need any special legislation. It's in federal legislation. It's one of the options there. So.
But that's a very good suggestion. I will bring that back to them.
Are there any other questions from members? Okay. Thank you, Dr. Henry. We appreciate it. We have a couple comments from the public. Marianne Hollingsworth.
Good morning. My name is Marian Hollingsworth. As a patient safety advocate, I'd like to point out concerns regarding the proposal to waive the requirement for physicians to prescribe buprenorphine. It seems dangerous and reckless for any doctor to have less training when it comes to prescribing any drug. Most doctors would be hard-pressed to name side effects of most of the drugs they prescribe. In fact, I talked to a cardiologist not too long ago who said he didn't know that metoprolol, for example, is a black box drug. Buprenorphine was one of the drugs given to Alex Smith the night he died of an overdose in an Orange County drug rehab facility. You remember the doctor in that case, Dr. Daniel Hedrick, was disciplined with just a PLR. Now, if a doctor with a pain specialty can have a patient overdose with buprenorphine in his own clinic, can you imagine how dangerous it would be for a doctor with no training to prescribe this drug? I urge you not to waive this training for physicians. School training is great. But 8 hours is not too much to ask for someone to be more qualified to prescribe this drug. Also, I was very surprised that Dr. Fishman claimed he didn't know who makes buprenorphine. It's also surprising that the board chose Dr. Fishman to make this presentation on
Sorry,
buprenorphine.
this is not Dr. Fishman.
I'm sorry?
It's Dr. Henry.
You got the wrong doctor.
You said Fishman. Isn't this a doctor?
No, Dr. Henry.
Dr. Henry? Dr. Fishman is not here to make the presentation?
No.
Okay, then I apologize
That's
because Dr. Fishman was the one scheduled to make this, and he does have a close tie to Big Pharma, and I would think anyone who works with him would know that, particularly since he works with Big Pharma, Purdue, particularly in making this. So I'm sorry, that's my mistake regarding this, but still, anyone who deals with this drug should know who makes this. And since he works with Dr. Fishman, who has direct tie, well, he has no direct financial connections, but Purdue did pay for the printing and distributing of his book. So I apologize for that, but there still is a concern about ties with Big Pharma. Purdue did just get a patent for a new novel version of buprenorphine. And if that is what works with Dr. Fishman, that is a concern for us. Regarding the training, it is the board's prime duty for patient safety, and I urge you to keep a training in place for physicians to prescribe this drug. Thank you.
Thank you. Eric Andrus.
I'm going to expand a little bit on what Marion was talking about. And did everybody get my packet that I sent them? Okay, thank you, Kim. It's interesting that Dr. Fishman is listed on the front page of this materials things and that he's not here. And on the second page in his disclosures, he says, I have no direct financial relationships with drug companies. Maybe not direct, but if you all got a chance to look at the front page of the packet that I sent you, I'm going to read through just some of this. Dr. Fishman and several other defendants are at least 80 of the more 430 lawsuits now pending in federal court, and a couple more dozen in the state courts, according to 2 plaintiff lawyers. While both editions of Responsible Opioid Prescribing were published by the Federation of State Medical Boards in 2007, the edition was written by Dr. Fishman, a Purdue key opinion leader. The Federation of State Medical Boards knew that it had received funding from Purdue to distribute responsible opioid prescribing. In fact, Purdue controlled the content and paid the authors of the publication. As a result, Purdue used both editions of Responsible Opioid Prescribing to put itself in position to have tremendous influence over medical boards throughout the country. The American Academy of Pain Management Corporate Counsel included Purdue and other opioid manufacturers, and the AAP Med's past presidents include Dr. Haddix, Dr. Fishman, Dr. Fine, and Dr. Webster, all of whom received significant financial payments from Purdue for promoting its deceptive messaging about opioids. Purdue provided $900,000 for various FSMB initiatives related to opioids, including $100,000 for distribution of responsible opioid prescribing and $50,000 to fund Scott Fishman's production of the book. Dr. Portnoy also admitted in a 2012 interview with the Wall Street Journal that he gave innumerable lectures in the late 1980s and 90s about addictions that weren't true. Despite these admissions, Purdue and its other KOLs continued their deceptive messaging about prescription opioids. In the face of Dr. Portnoy's admissions, Dr. Fishman also gave presentations and lectures in Colorado as a KOL for Purdue from 2000 to 2010, similarly promoting opioids. Purdue hired additional healthcare providers like Dr. Portnoy to act as KOLs, and the assistance of KOLs from front groups. Purdue set out to promote the hypothesis that opioids were safe and effective treatment for chronic non-cancer pain as fact. The KOLs included Dr. Webster, Dr. Fine, and Dr. Fishman, who were also affiliated with the front groups discussed above. With the policy in hand, the FSMB decided to spread the word that the nation's physicians by translating the policy into a book, and it's delegated that task to Dr. Fishman, a University of California Davis physician who also works with pharmaceutical companies that market opioids. FSMB reached out to a total of 6 opioid makers requesting financial support to produce and distribute responsible opioid prescribing, a physician's guide. I will, thank you. But it won't disclose how much each company contributed. I think we have to question Dr. Fishman's affiliation with this presentation and what they're talking about, because he was the one that led the opioid epidemic.
Thank you. Are there any other comments from the audience? Any comments on the phone?
No comments from the phone at this time.
Great. Okay, let's move to item 18, discussion and possible action to amend Title 16 California Code of Regulations, Section 1309, 1360, 1360.1, 1360.2, regarding rehabilitation criteria and substantial relationship criteria, and to repeal Sections 1379.68, 1379.70, and 1379.72 regarding rehabilitation criteria and substantial relationship criteria. Ms. Webb.
Thank you for that introduction. I'll provide some further explanation. So, members, this is what needs to be done in response to AB 2138 that passed last year and will become effective July 1st, 2020, that changes the board's discretion to use convictions and disciplinary actions from other licensing agencies. As of July 1st, 2020, the board will not be able to ask people to disclose convictions. And like I said yesterday, the board will still be fingerprinting, and we should be able to pick up most of those and be able to ask applicants about them, unless they fall into some of the categories that this bill will prohibit us from exploring. So the goal of this bill is to reduce licensing barriers, and it applies to all DCA boards, including all of the healthcare boards. The board objected passionately and frequently, but it passed anyway. And so we are going forward as required at this time to amend the regulations so that they become effective as of July 1st, 2020. The board already had regulations in place to guide us to determine what types of acts were substantially related to the practice of medicine in our other practice areas, and also setting forth criteria on rehabilitation. So those are already in existence. This asks the board to make some adjustments to be consistent with AB 2138. So the first thing I want to talk about is on page 18-5, that's substantial relationship criteria. And, as you know, the board licenses and regulates physicians, but also licensed midwives, research psychoanalysts, and polysomnographers. Polysomnographers, when those regulations went forth, they had their own sections related to these materials added, but our other licensees for allied professionals don't. And what I am proposing is that we repeal the ones specific to polysomnographers, have all of our licensees addressed under the same regulations. And so I have made some adjustments to strike the Medical Practice Act, because we have other acts that are applicable, and I put some additions in the bottom part there under the note to reference statutory sections that apply to our other licensees. So the main part of 1360, substantial relationship criteria, is under subdivision B, where it adds the 3 things that the board must consider when determining whether a crime or act is substantially related to the professional practice. And that is the nature and gravity of the crime, the number of years elapsed since the date of the crime, and the nature and duties of the licensee. So the other piece is rehabilitation criteria, and that's addressed in several of the board's regulations. If you turn to page 18-4, that's rehabilitation criteria for denial of licensure. And the first part there, the underlined part, it's AB 2138 asks this board to consider deeming a person who has met all the requirements of parole or probation and they've completed their criminal sentence, to consider deeming that enough to establish rehabilitation. It doesn't force the board to only limit the analysis to that, but that is an option the board can take. I do not recommend that option. There's case law and just writings that indicate we expect people who are under a criminal sentence and are being monitored to behave exemplary, to complete this without violating the terms and conditions. And so it's not really a good indicator of rehabilitation, the fact that they have completed those requirements. And so there is this option to add additional factors to consider, and those are included on page 18-4, the subdivisions A1 through 5, that dive in a little bit deeper to the nature of the act and the length of the parole or probation. And you'll see, I don't think I have to go through every subdivision, but it gives the board more things to consider to determine whether someone has demonstrated rehabilitation. Mm-hmm. If the board determines that they have shown rehabilitation after reviewing these factors, then the analysis is done and they're qualified for licensure, barring other restrictions. What is good is that the legislature did change it where it doesn't restrict our ability to put terms and conditions on if that's necessary for public protection and rehabilitation. Prior versions put restrictions on the board's ability to do that or limited the time period. So this is just about denial and not putting conditions on when it's necessary. So that is the good news. Under subdivision B, if the applicant has not demonstrated rehabilitation under subdivision A, then the board goes to subdivision B. And this mostly has all of the criteria that's in our existing regulations. So it's a further look to see if, maybe they had a violation with their probation or parole, so they don't qualify under A. We go to subdivision B and see if under that criteria they're able to demonstrate rehabilitation. This is what's required under the law. this is what's included in the amended regulations that are being proposed here. So this is under 16 CCR 1309. Luckily, our rehabilitation criteria for suspensions and revocations on page 18-6 and our rehabilitation criteria for petitions for reinstatement on -7 follow that same pattern. So the board considers if they've met it based on the fact that they've completed their criminal sentence without an issue, given our additional factors that we look at. If not, then we go to subdivision B and do the analysis under that. So what I would like to propose is that the board approve the language proposed and authorize staff to follow the regulatory process with the review through Department of Consumer Affairs and Business Consumer Services and Housing Agency, and to make non-substantive changes as necessary. And I already see an example of something I'd like to adjust. So I try to get internal consistency. You'll see under on page 18-7, B1, says the nature and severity of the act. The new language uses gravity of the act. And so, I'd like to, that's an example of a non-substantive change just to make it internally consistent, change severity to gravity. And then upon approval from DCA and agency, file it with the Office of Administrative Law for its 45-day comment period. I would also like some flexibility that if DCA and or agency do not like the striking of the polysomnographer sections for inclusion with all of our other licensees, that I model their language after what's being proposed here and not have to bring that back to the board. It would be virtually identical language. I'm just trying to reduce the number of regulations where I can, so that's my proposal. But if it's not accepted, to keep them in their own section and use the same criteria as required by AB 2138.
Okay.
So if I make this motion, do you need them separated out to amend 1309, amend 1360, and can we just make a motion as a total package?
Yes.
With edits?
Yes.
So I'm going to make the motion.
Yeah, just I think if you authorize staff to make non-substantive changes, that will do it.
So I'm going to move that we accept these proposed amendments with staff making non-substantive changes.
Second.
And also in that authorization, if the repeal of those 3 sections are not permitted, that I can model this language without bringing it back to the board.
Yes, so add those proposals to the motion.
Okay, thank you.
Okay. Are there any comments or questions from members? Dr. Gananadev?
Kerry, I don't think you could have made it more complicated even if you wanted. But we support it.
Any other comments or questions?
I think.
We do have someone who wants to speak on this from the audience, Marianne Hollingsworth.
Good morning. My name is Marion Hollingsworth. AB 2138 is basically a leap of faith that boards have been put into the position of, I think this program is great for nonviolent offenders, nonviolent felons who offend while being basically young and stupid and are seeking a second chance. However, I do have issues with established adult professionals who clearly knew the laws and chose to break them anyway. This could affect many doctors with license applications that are now before the board. There is considerable recidivism among doctors who offend. Look at the number of addicted doctors who routinely violate their probation by skipping their mandated drug tests. They know that because they are doctors, they will be given the benefit of the doubt much more often than a young offender, possibly like a 25-year-old parolee. In working with this new law, the board needs to be more vigilant when granting licenses to people who come under this program. Consider your duty to protect the public first when considering a license, and I trust you will do that. Thank you.
Thank you. Are there any other comments from the audience? Any comments on the phone?
No comments from the phone at this time.
Ms. Cruz-Jones, can we get a roll call?
Dr. Bolat.
Aye.
Ms. Friedman.
Yes.
Dr. Gonadev.
Aye.
Dr. Hawkins.
Yes.
Dr. Kraus.
Aye.
Ms. Lawson.
Yes.
Ms. Lubiano.
Yes.
Dr. Lewis.
Aye.
Mr. Wormuth.
Aye.
Ms. Wright. Dr. Yip.
Aye.
And Ms. Pines.
Aye. Let's move to our next agenda item, 19. Presentation and update on changes to postgraduate training requirements effective January 1st, 2020. Ms. Alameda?
Good morning.
Good morning.
I'm going to go ahead and provide an update on where we are with the changes that are effective January 1 of 2020. So just a recap of what the changes are. Effective January 1st of 2020, the postgraduate training requirements have been extended to the 1 to 2 current years to 3 years for all applicants, regardless of the medical school that they attended, as domestic or international. Of those 3 years, they do have to complete 24 months in one program, and the 4 months of general medicine is still required. The board will be issuing a postgraduate training license to any individual that is participating in a California ACGME program. This training license will not be required to be renewed. It will be displayed on our board's website, just like you see a full and unrestricted license. And an individual will have 180 days to obtain this license in order to continue in their training. The board will no longer recognize international medical schools. We will be utilizing the World Directory as meeting the educational requirements for licensure. So where are we? What have we been doing since January 1st of 2018? A lot. Lots to do, and we are definitely on track. So a letter went out June of 2018 to all the California programs just introducing the change and letting them know how to get a hold of us, how to stay informed, and and allowed them to contact us for additional information. We've also been working with the department to update the Breeze online system to allow individuals to apply online. We are also on track to go live with that January 1st of 2020. We released a podcast in December 2018. It's posted on our website. We've been doing interactive webinars since January. We do them monthly. Our last one will be in June. This webinar, the first webinar that we did in January, is posted on our website for anyone to view. It was really nice. It gave the programs the opportunity to, through the chat box feature, to ask questions. We read the questions out loud and answered. We do monthly forums with staff. This is a brainstorming session to just get feedback from the staff on what we need to do internally to make sure that we remain efficient and keep our timeframes within the current timeframes we have now. We do have a web page that was just updated this last week regarding some information. We'll be building on that as we get closer. We'll be updating providing applications on our website. We hope to have that in the fall, but we'll just be building on the website for the frequently asked questions and answers. We're also working on a web portal, which I'm really excited about. This is really going to streamline our process. We're working with our IT folks, and this will allow California programs and medical schools to submit primary source documents to us via a secured portal. That's going to save a lot of time. We've identified workflows and procedures. So things that we'll be working on for the remainder of this year is finalizing our procedures. We're going to be reviewing every pending application that we currently have on file, and we're going to be notifying the applicants of what their particular situation is and what they need to do during this transition. Additional information will be posted to our website. We'll be training our staff. We'll be continuing to do outreach. We'll continue with our monthly forums. We're going to develop some tutorials to post on our website that's just going to walk individuals through the application process, the documentation that they need to submit in order for a training license or even a license to be issued. And then we go live January 1st, 2020. I've provided some common questions that we've received throughout the last year and a half or so. That I feel are just important. This information will eventually be on our website, and we will build from this. A question that we have received is, an applicant that completes a combined dental and medical degree program, are they eligible for licensure? And the answer is yes, as long as that program is CODA accredited. And a DEA permit. Can an individual get a DEA permit? And yes, an individual is eligible for a DEA permit. And an individual is also able to enroll as a Medi-Cal fee-for-service provider. And I'm sorry, what I'm referring to is someone that's holding a postgraduate training license. These questions, individuals and programs are just wanting to know, are there any restrictions with someone that's holding a training license? As far as an X license or a fluoroscopic permit, we have been informed by California Department of Public Health that will not be eligible for a holder of a training license, that you do have to have a full and unrestricted license. As far as the duties that an individual that holds a training license can perform, they can diagnose and treat patients, prescribe medication, obviously with the appropriate permit, sign birth and death certificates, and anything within the scope of their training and authorized by their program director. So these training licenses that are going to be issued, it's not going to be just a set 3-year training license. That training license is going to be issued and valid depending on an individual coming in, and maybe somebody that has completed training in 1 year of training in another state, they're coming here to do their last 2 years, then that training license is just going to be valid for the remainder of the time that they need before a license is required. Because after 36 months of approved training, a license is required. They can't, so for individuals that are taking a program that's a 4-year program or a 5-year program, a license is required after the 3 years. If they don't obtain that license, they will not be able to continue in their program. So when January comes and someone is in a training program, they will have until June 30th of 2020 to obtain this training license. Again, for individuals that already have a pending application on file with us, we will be reaching out to them. They're going to actually get a letter from us by September that's going to let them know exactly what they need to do for their transition. So this is more applying to individuals coming into California to a fellowship program. If they've completed their 3 years, they're ending that program on June 30th, but they're expected to start in California July 1st. The question is, can they start that program? How quickly can we get that license to them? The law does allow a 90-day grace period for that individual to obtain their full and unrestricted license without any interruptions to their program. And like I said, during the transition, we'll be notifying all of the applicants that this is what you need to do, and they'll have that out by September. And that is where we are. Are there any questions?
Thank you, Ms. Almeida. Dr. Gananadev?
Thank you, April. You've been doing an yeoman's job on this one. This is not easy. I think I'm taking the brunt of a lot of criticisms of why we did this. But first thing is I want to make sure that we actually send this out to all the GME departments where the graduate medical education training is, because program directors are the ones who are really concerned how to proceed. So I think you have an excellent presentation. If you send it to them, they will distribute and they can explain to their residents what's needed.
So what we've actually done is that the January webinar that we did with this presentation, it's posted on our website, and an email went out to all the California programs letting them know this is now available on our website, and we provided a link.
Okay. And you mentioned something about 4 months of internal medicine. Is that during medical school or residency?
Residency, general medicine, yes, 4 months of general medicine. It's the requirement now. That has not changed. It still will be the requirement.
Lot of straight programs don't have any 4 months of internal medicine rotation. That's why I'm just curious. So surgery never does, orthopedics never does, radiology has, but many programs don't. So,
well, it's required, and on our documentation, they do certify that an individual has completed 4 months as part of their residency program.
They all do.
There is
That's
no
another
requirement in general surgery. That's why I'm just curious what ACGME accreditation doesn't require that you have to do internal medicine 4 months rotation. I mean, they do other rotations like ICU and all that, which is medicine, but not internal medicine. Okay. I mean, there are many rotations which could count as medicine, but there is no separate internal medicine rotation, because many programs about 20 years ago went all to straight residency without a transitional program, where they did a lot of other rotations. Now they're all straight 5 years, or straight 4 years, or neurosurgery is straight 7 years. So their medicine you can consider comes out of ICU, burn, which are critical care units. So, okay, thanks.
Any other question? Dr. Yip?
Thank you. I think the board or DCA can communicate with the Department of Public Health that the PTL holders should be allowed to take an examination and certified fluoroscopy use. 3 is a long time. For example, urology, orthopedic, GI, we use fluoroscopy all the time. If the PTL holder cannot take an exam and get a license, it means someone has to be in the room when they're doing a case, which really not effective training. Thank you.
So, Dr. Yip, there was a bill yesterday we discussed that would eliminate that fluoroscopy permit, but we'll go back and look at that and make sure it's not only for a licensee that holds a full physician and surgeon license, but we can add maybe a postgraduate training license to that language, and hopefully the author will take that recommendation. So we'll make sure it covers both of our licensees.
Dr. Bolat?
April, amazing job. It's been a lot of work, but I think the only unfortunate thing is it's PTL, so it sounds like PTL, which we tried to get rid of. But I'm curious about one thing on BRD 19-5. It says, can a holder of a PTL request enrollment as a Medi-Cal fee-for-service provider? And I'm curious about that because the PTL holder is not going to be billing unless they're moonlighting.
And they can moonlight.
And they can moonlight.
They can moonlight.
That's right. Okay, so that's the reason.
As long as as long as the program director authorizes as part of their residency.
So
in some cases they may. And this was one of the questions that came from one of the programs. They were concerned about this, so it could be that they are allowing that.
Yes. Yes, and my question to that is just it's going to be interesting in the field because with Medi-Cal, people go between fee-for-service and Medi-Cal managed care, back to fee-for-service. So that can be very tricky. Happens every other month for some folks. The other is going to be the duties in connection with an ACGME accredited postgraduate training program in California, including its affiliates and approval by the program director. So it means including affiliates of the program, or does it say if it's an affiliate, and an affiliate can be loosely defined, I think. Or if I say, well, I think you can go work over at this FQ8C, it's okay, but it's not an affiliate. Does this sentence mean that it needs to be an affiliate?
It can be its affiliate, but it can also be something somewhere else if it's authorized.
Got it. Okay. All right. That's the way I just wanted to clarify that. But otherwise, thank you for an excellent presentation.
Any other questions from the members? Okay. Any questions from the audience? Any questions on the phone?
Presently, I have none over the phone lines.
Okay, thanks. Moving to agenda item 20, update from the Attorney General's office. Ms. Castro.
Good morning.
Good morning.
So today our report is going to cover 2 Court of Appeal cases that we'd like to bring to your attention, staffing update, and just a very, very short transition report. So the Health Quality Enforcement section is going to be assisting the medical board in continuing to pursue its public protection mission in light of 2 recent Court of Appeal decisions that weigh heavily on the favor of patient privacy, but that I don't believe will impede your very important mission. In the Graffalo versus Cohanshohet case, which was decided January of 2019, the medical board had previously received an anonymous complaint in October of 2014 that Dr. Cohanshohet may have been excessively prescribing controlled substances to his patients. The board opened an investigation. Dr. Cohanshohet's cures report was reviewed by a board medical consultant who identified significant concerns with his prescribing of controlled substances to 5 patients. Specifically, the medical consultant identified the combination of high-dose opiates combined with benzodiazepines and a muscle relaxant, which potentiated the sedation of this patient to the point of potential respiratory arrest and increased the risk of morbidity and mortality. In June of 2016, the board issued an investigational subpoena pursuing patient records, as it's allowed to do under Government Code Section 11181. What the medical board pursued was the treatment records concerning 5 patients, and for a very limited amount of time of 1 year. So it's already curtailed and identified that this is what the board needed to pursue the investigation in that case. In April of 2017, with the assistance of the Attorney General's office, a petition for an order to show cause was filed in front of the Superior Court, requesting the pursuit of these patient medical records. The Superior Court granted the board's petition and found good cause for the disclosure of the medical records. And not only did it find good cause, but enough good cause to overcome the patient's constitutional rights under the California Constitution, right for privacy. Dr. Cohanshohet appealed to the Court of Appeal and asserted patient rights and patient privacy rights. The Court of Appeal reversed the Superior Court and held that the board had failed to establish good cause. And the court expressly held that good cause required more than the mere fact, and this is what was found in this case by our medical consultant, that a pain management specialist had prescribed in doses greater than 100 MEDs. The appellate court imposed additional requirements on the board in order to establish good cause. And specifically, the board needed to make a higher showing of how often similarly situated physicians who specialize in pain management might prescribe the drugs in question. They wanted to see the percentage of the total number of patients that Dr. Cohanshohet treated, and also wanted to see the likelihood that the prescriptions could have been properly issued. So that was the Court of Appeal case and the Cohanshohet matter. Shortly thereafter, on April 2nd, 2019, we received another Court of Appeal decision, and that one is Graffalo versus Wolfson. In the Wolfson case, the Medical Board of California also opened an investigation after it received a law enforcement report in December of 2014 alleging that Dr. Wolfson was overprescribing. Again, Our medical consultant identified very concerning departures from the standard of care based on the allegations and based on the cures report. And we found 5 patients for closer review. And again, requested a release from the patient. Patient didn't provide the release, and we moved on to a subpoena enforcement matter. In that particular case, there was a pattern and practice identified in the cures report of high doses of opiates combined with benzodiazepines, which again can potentiate the sedation to the point of respiratory arrest and increase the risk of morbidity and mortality. In September of 2016, the medical board issued a subpoena requesting the records, and again, like I said, for a very curtailed and finite medical record period. And again, we went before a Superior Court in October of 2017, and again won. The Superior Court finding good cause enough to overcome the patient's privacy rights under the California Constitution. Dr. Wolfson appealed and asserted patient privacy, and the Court of Appeal reversed the Superior Court. And it held that we needed more good cause. It expanded on the prior Counsel finding and essentially set forth more, a little bit more of a showing by the medical board in order to weigh in favor of good cause to obtain patient medical records. The takeaway from Counsel and Wolfson is that a heightened good cause requirement will be necessary in your pain management cases. And this is based solely on the appellate court's concern with patient privacy, which is a good concern for them to have. And although not specifically articulated in either case, they're interested to see in a less intrusive means of obtaining evidence short of the patient medical records. We will be working closely with the medical board staff to provide recommendations on how these 2 Court of Appeal decisions can culminate in still pursuit of your public protection mission. And understandably, these 2 Court of Appeal cases bring us back to the drawing board. And essentially, your mission does require an analysis of patient medical records in addition to cures database. Why? Well, you want to get into the doctor's head at the time contemporaneous with the prescribing that brings into issue concerns on pattern and practice. And so we believe that the medical consultant did a really good job on this. We obviously wanted to get the medical records, but we'll have to reanalyze how we do that because at every single one of your board meetings, you seem to have a presentation on the importance of identifying this public health issue of overprescribing and deaths by patients inadvertently in most cases, but still tragic. Moving on to our staffing update, I'm very, very happy to report that even though we have a very high retention rate in the health quality enforcement section, people do retire when it comes to their time. So I'm pleased to introduce, I have one of the deputies here. We hired Sarah Jacobs in Fresno. She's been with our office for 6 months in my section, health quality enforcement section, but she previously served for 10 years in the appeals, writs, and trials section of the criminal division of our office. And she comes with a deep wealth of knowledge and passion in this particular arena, and she's already hit the floor running. Another hire, internal, is Caitlin Ross. Ms. Ross joins the San Francisco section, and she previously represented CDCR, so she comes with a lot of institutional knowledge of how medicine is practiced in big institutions such as the California Corrections and mental health institutions. And we believe that she brings a lot to the table, especially with civil litigation, which is part of the board's reality as well. We represent you in all, and we defend you with most, if not all, of your civil litigation needs. And then we hired in Los Angeles Ms. Jocelyn Park. She is a former JAG with the Navy. We're happy to welcome her. Jonathan Nguyen, he's a former ABC, Alcohol Beverage Control staff attorney, and Mr. Brian Roberts, a former district attorney. And so DOJ and HQE generally are highly desirable places to work. We're very competitive in our hiring, and we have been able to attract the best lawyers in the state. interested in wearing that white hat and protecting the public, and best of all, serving you. I want to thank Ms. Pines and Dr. Lewis and Dr. Yip for continuing to assist all entities involved in the transition process following the repeal of the vertical enforcement model. It's a major change, and I'm happy to report that even though we went from being jointly responsible of 1,800 cases to now about 60 investigations statewide, selected by the Health Quality Investigation Unit for co-assignment to a prosecutor, we've taken this change in stride, and we're keeping an open dialogue to make sure that you're assisted in anything that you need, whether it's training or just insights generally on how to continue your important work. Our staff will continue to identify needed process changes, but I think we've identified almost all of them. And again, we thank the medical board for continuing to want to hear from us at their medical board meetings. And staff has been working very, very hard on making sure that we file every case that comes to us within the confines of making sure it's quality and that the evidence is there. And we just anticipate requiring a little bit more of a lead-in time to the extent we start seeing cases that we've not handled previously under vertical enforcement. And I truly appreciate that all the health quality enforcement deputies, paralegals, and analysts can-do attitude and die-hard commitment to protecting the public. That's it. No, thank you.
Dr. Gonanadel?
Ms. Castro, thank you so much. On these two cases in the appeals court, what are our options other than correcting internally? Can we do anything to appeal to the next level, which is the Supreme Court, or can we have a legislation? You mentioned California Constitution because legislation might not be able to do something. So can you explain to us?
Yes, we considered all of those options, and this is the law now, basically the published case law. Everything is possible, so if there is a way to manage a doctor's aversion to producing medical records to you, perhaps that is a good place to see what can be done. Patient privacy is a big concern. Obviously, I think that patients have more information and therefore know that their data is being shared. Obviously, we feel that we should be able to see that data when it comes to protecting the public, but at the same time, patient privacy bears very heavily as well. We take every effort to protect privacy of the patients. And and so here's the good news. The good news is that even though vertical enforcement has been repealed, we are very, very involved in interim actions. One of those types of interim actions are subpoena enforcement cases, and we will be committed to ensuring that you have a strong legal hand and that we make these recommendations to Ms. Webb, Ms. Kirchmeier, and Ms. Nichols, and we'll see what happens. And so we have had a very long line of subpoena enforcement successes in the Superior Court, and this is the first two cases that we have lost in 7 years since I've been a senior Attorney General's office. But even though we lose, the patients won in the privacy arena. So it's a balancing act, and I'm optimistic that we'll be able to still exert your important public protection mission. We might just have to go through a couple of extra hoops, and we'll make recommendations.
So in your feeling is that it's clear enough in the appeals court decision that it's not worth looking into appealing further?
Well, the appeals process has expired, and we did make recommendations, and here we are.
Okay.
So no, that ship has sailed, as they say.
Does that really put a big break on for us to get the medical records, and a lot of this death certificate project, a lot of projects we're looking at, we need the medical records. Does it really hinder that process?
I think on the death certificate project, and that is where the medical board receives information from the California Department of Public Health on coroner's reports. There's no argument that that for that patient who is no longer a patient, they're a deceased, we get those records. So we believe that those are still okay. The next of kin are the ones that are involved. There's no longer a patient, but there already has been legislation to try to speed that acquisition of medical records in those cases where the patient is now deceased. It's the live patients that have more privacy interest under the California Constitution.
Any other questions? Ms. Lubino?
Thank you. Thank you, Ms. Castro. With respect to the heightened good cause requirement, are you able to share now what steps we will be taking to help meet that burden for future cases?
Probably not, because I would like to make those recommendations within the confines of attorney-client and have all of those recommendations assessed, but it'll be up to Ms. Kirchmeier to decide whether it's something that we need to share publicly.
Okay. Thank you.
Any other? Dr. Yip?
Thank you. Maybe the staff can help to send a link to us so that we can read the cases in detail to learn something. The second note that since you're our own legal counsel, what would you advise the board moving forward to even may take legislative changes to create a system or platforms that consumer can actually appeal a case if they feel a medical consultant, expert didn't do their job, they never mentioned that they didn't do a job, that they have a way under certain criteria that they can appeal a case and we can open the case, look at it. So.
I personally don't have many thoughts on that other than I did attend the patient advocate meeting, and that a lot of really great suggestions were made. We heard any number of things that might address allowing someone to be between the patient and the board that addresses those concerns. I think that there's always room for improvement on every level on the medical consultant front. These two cases provide a very good jump-off point to discuss what medical consultants can be looking at when they look at cases. So I think that it's a good opportunity to do that. So.
Okay, thank you.
Thank you.
Are there any public comments from those in the audience? Ms. Ree?
Yes, hello. Dr. Ree of Black Patients Matter. So we do have some concerns, significant concerns about what's occurring at the HQIU. We understand that we're all here for the patient, but as was stated by Ms. Pines as well as at the advocate meeting, it's just a little concerning that the DA's office, when they investigate cases, they actually never consult the family members of the patient or follow up with them or to give them updates. So that's a little concerning. And also, as I repeatedly state, that when we look at the leadership at the DCA, it's actually pretty homogenous. There really is no racial diversity. And so putting that together with today's speakers and looking at PrEP and looking at racial disparity and treatment outcomes and reviewing the articles that I submitted in terms of patient preference.
Dr. Ree, the agenda item is the Attorney General's office update.
Yes,
do you have a comment relevant to that?
Yes. So I thank you. I just want to state again that the decisions and what's occurring within the DCA, HQIU, and their hiring practices is questionable in that it could be adding to the problems. We believe that it is adding to the problems of racial disparities that are seen in patients. Thank you.
Thank you.
Just real quick, somebody tried to call in on number 15 and had some technical difficulties, called in later, and they wouldn't let her talk. Again, you should all listen to the Hughes hearing from yesterday. It's extremely concerning, and it's related to the Attorney General's office, although I think the Attorney General's office did the right thing in that case, but it's a problem, I think, with the medical board. It should have been officially mentioned here, I think, in this. I have another clip to play, hopefully. This is former board member Judge Catherine Feinstein a couple of years back.
But I'm also seeing that people can be harmed in 550 days is a very old case. If it were a criminal case, it would be dismissed for violating speedy trial right. I got to be honest with you. We did a case yesterday that ended up being dismissed, in which the DAG had filed a discovery motion for necessary evidence 4 months before the hearing date and never obtained the evidence, didn't have the evidence to move forward, and took no action to enforce the discovery order in a 4-month period. And that's no enforcement. That's not a matter of vertical or non-vertical. And legally, there's nothing else there was no evidence. I mean, it wasn't even debatable that it was a case that could proceed.
And I'll have to get that case name from you, Kim, the one that Judge Feinstein just mentioned. I don't know if that's a vertical enforcement case, first of all. If we're having difficulty with evidence at trial.
No, please, let me make it clear. Mm-hmm. I understand what difficulty with evidence at trial is. I don't understand what the point is of filing a motion and then letting it sit for 4 months and not taking any steps to seek enforcement. So you don't have any evidence. So let me just make that clear. I mean, I'm not overly impressed yet, okay? Hopefully that'll come.
I've asked at least 3 meetings now for an update on this very thing that Judge Feinstein talked about, and Ms. Castro said she'd look into it. We've not heard a report on what she found. Isn't anybody else interested in what happened with that? This is what I meant yesterday by topics of being ignored and then just disappearing. Shortly after Judge Feinstein said this, she mysteriously disappeared from the board with no announcements whatsoever. She must have been on to something. Judge Feinstein, if you're listening today, we appreciate you trying to take a stance.
Thank you. Are there any additional questions from the audience? Any comments on the phone?
No comments from the phone at this time.
Okay. Moving to agenda item 21, update from the Health Quality Investigation Unit, Mr. Chris and Ms. Nichols.
Good morning. My name is David Chris, and I'm the Chief of the Department of Consumer Affairs Division of Investigation, and this is Deputy Chief Kathleen Nichols. We will be providing an update on the division's Health Quality Investigation Unit. HQIU currently has 10 investigator vacancies. There are currently 11 investigator candidates in background, and all 11 have their post certificate and will not require the 6-month police academy. There are currently 3 investigators attending a 6-month police academy. 2 will graduate in June, and the 3rd will graduate in August. HQIU will be conducting a 3-week mini academy for 17 newly hired investigators to provide specialized training on all investigation types. This classroom training will take place for 1 week in July, 1 week in August, and 1 week in October of 2019. HQIU is also conducting training for all supervisors in June of 2019. Medical Board CCU managers will also be joining us for this segment, and we can share efficiencies and continue our good working relationship processing cases. On April 26, 2019, the Division of Investigation held its 2nd annual Staff Appreciation and Recognition Ceremony. This year, 10 of the 12 award recipients were from HQIU. The awards recognize staff for exceptional performance, creativity, organizational abilities, work success, and teamwork. Several factors have contributed to the case aging at HQIU. In November of 2016, the investigator vacancies reached their highest point with 40% vacancy rate. These vacancies definitely contributed to longer case completion times. I'm pleased to say that we've hired our way out of the vacancies, and for the current fiscal year, our average investigator vacancy rate is 9%, which is in line with other state agency vacancy rates. The exceptional staff we've hired are being trained to continue the high-quality investigative work we provide to the medical board and allied health agencies. Another main contributor to case aging is the reduction of medical consultant hours. This reduction is causing significant increases in the time for case completions. We discussed this problem previously with the board, and with your support, received approval for a budget augmentation, including additional funding for medical consultant hours. This budget change proposal is pending final approval in the legislature, and I'm optimistic that July 1, we can increase the medical consultant hours to assist with the workload. Thank you for your support and assistance with this important item that was causing delays in our investigation. An additional significant impact to our case aging was the addition of the medical board's death certificate project, which referred an additional 247 complex death investigations into the HQIU field offices for patient deaths in the years 2012 and 2013. This group of complex cases presented an additional challenge because of the statute of limitations on these cases. There's a 7-year treatment statute of limitations, and this group of cases had to be prioritized so we could complete the investigations prior to the expiration of the statute of limitations. We fully support the importance of this project and the benefit for California consumers, but we'll need additional positions to be able to keep up with the workload if the project continues. If the board wants to significantly better outcomes in enforcement, I have 3 recommendations for ideas for the board's consideration. First, HQIU ran a successful pilot project where we hired non-sworn investigators to assist with the lower complexity investigations. These investigators completed high-quality work for the board, and there was no permanent funding to keep them. We've been losing them as their limited terms expire. As they leave, their caseloads need to be redistributed. And currently there are 4 non-sworn special investigators left, and 2 of these depart next week. I can't stress enough the importance of these non-sworn positions. The DCA model at other boards and bureaus is to have the less serious, less complex investigations be worked by non-sworn investigators, and send the more complex, serious investigations to sworn DFI investigators. In my view, the number one thing that we could do to produce timely investigations and to achieve greater public protection is to tilt up a permanent non-sworn investigative unit. HQIU consistently has a higher workload, including more processes which directly impact investigator retention. We've gone to great lengths to recruit and hire the positions and fill vacancies. If nothing's done to reduce the massive workload, investigators will continue to leave and work for other programs or other agencies with a more manageable workload. A manageable caseload for complex investigations is 15 cases. We need to implement solutions to attain this number so we can keep investigators at HQIU. We're asking that this proposal be reinvigorated this year so we can move forward towards reducing case aging and improving investigator retention at HQIU. Second, another impact to case aging is spending investigator time on non-investigator tasks. We are recommending a change to the process to consider centralizing the expert review process. Currently, investigators spend time locating experts, packaging materials for experts, and sending cases to experts. The case continues to age after it's been completed, and there are no more investigative tasks. When the expert opinion is received, time is spent reviewing, obtaining addendums, and further communication with experts, which might be accomplished better in a centralized format with non-peace officer staff. Third, I want to address how HQIU case aging days are calculated. Currently, this includes the processing time by MBC after the investigation is completed, as well as the medical consultant and medical expert time. We are working with board staff and DCA to develop new reports for HQIU that will clearly articulate the actual investigative days time frame and also show the length of time that the medical consultant and expert process is taking. That concludes our update, and we'd be happy to answer any questions that you may have. And I also just want to say thank you to the board for your continued support of our program. It's been phenomenal over the years, and we're getting back on our feet. Thank you.
Thank you.
Should we take a moment together or individual questions?
What are you talking about?
Questions, Phil?
Dr. Gonanadev has a question. Okay.
Mr. Chris, I'm thrilled to hear that your vacancy rate is only 9% now. So my next question is, where is the beef? When are we going to see the decrease in the times? That's our number one concern, is how long it takes. We just heard Judge Feinstein's comments about how long it took. So I'm just trying to see how, with the appropriate staffing now, are we seriously looking at the process, how to cut down the times?
So we're anticipating being fully staffed late summer of this year. And then we have a number of staff in training. And, I'd like to say that, staff would be, fully trained, and, we'd be back to normal soon. And then I think we'd be able to see a reduction in those numbers. Kathleen, did you have comments?
I think some of the issues have to do with the pending caseloads right now. Back in 2012, 2013, there was approximately 1,000 investigations statewide. Right now, as we sit here today, my staff have over 2,000 investigations that are currently in our field offices with the same number of staff that we had before. So when we're talking today about the proposal of creating permanent non-sworn positions to deal with the less serious, less complex cases, that's important. It's important to take off the less serious cases so that the sworn investigators can work faster on those more urgent cases that could cause harm to the public.
Dr. Lewis?
I know I've asked this question multiple times, and I'm glad to hear that your staffing is up, significantly up. But I worry about the attrition rate, because the workload is so, arduous compared to other agencies which would pay similar rate, correct? And R&R. And we don't provide your funding, you're under DCA. So I just worry about the R&R and your attrition rate, because we could be okay today, but what happens tomorrow?
The medical board actually does provide our funding for HQIU. One of the things that the other programs in the other sections of D of I that our staff are flooding into because they have a reduced workload, they don't handle the expert process for all the other boards. So they investigate cases for the nursing board, but when they're done with the investigation, that's done through the nursing board. Those D of I sworn investigators are not part of the expert process. So that was another one of our recommendations to, you're using valuable sworn investigative hours to do more analytical tasks that might be better served done by a centralized group where you can control the quality, control the communication with experts, get a better work product for your expert report.
So I may have misspoke, because I assume that some of the funding came from DCA, but you're telling me zero comes from DCA. So you have to work on other ways of getting more money for R&R, right?
Yeah, so
that
is correct, and so over the last few months we've been meeting with board staff to kind of, just look at some efficiencies that we can make that don't involve spending significant money, because the money's limited. The budget is the budget, and so maybe doing some of the recommendations that we talked about today on having non-peace officer staff take over some of those responsibilities would allow the caseloads to come down, and so that's kind of, we're trying to maximize efficiencies.
And you don't need the sworn officers to do some of those duties. Is that what you're saying?
That is
it's
correct.
Expensive.
They are expensive, and there's a lot of very time consuming, and there's a lot of efficiencies that we think that we can gain, and so the board's been very, very helpful, and we are discussing some of these things, and the board as a whole has been very supportive of us in the past, and board staff has as well with these current ideas. We're trying to kind of talk about them and continue to explore efficiencies so that we can retain that staff, because it takes a long time to actually get them here, get them trained, and then they become effective, and then to leave because the workload's too high.
Well, we support you. I can tell you that. We support you.
Yeah, and we greatly appreciate that.
Dr. Bullock?
Thank you very much. So I was an expert reviewer for quite some time, and I'd like to know a couple of things, and I'm really glad to hear that there's going to be some energy and effort going into the training of the reviewers. But right now, what percentage of the documents do you receive that are handwritten versus coming from an electronic health record?
I would say the majority now we're getting electronic health records. That's a huge percentage now, and each system is different, and they all have their own softwares and their own way of, outlining the records.
Absolutely, and I think one of the interesting pieces of that if the majority are typewritten, that, utilizing and thinking kind of ahead, because what used to take hours would be to get 23-inch binders and go page by page by page to read, that if you were using any kind of algorithms and try to start to come up with NML and things like that, where you can actually, the computer's going to read those things, and I'm not suggesting we need to put that type of thing together, but I think that's going to that's going to make a big difference so that you can actually start to learn these patterns and see how we can make an impact in a much more obviously efficient way, because waiting 4 years and 2 years and 5 years is just not going to help any of us. But congratulations on getting your down to 9% and looking forward to seeing how it all plays out. Thank you.
I have a question about the non-sworn officers. So because they termed out, were they put in place to temporarily deal with the issue around vacancy? So now
That's correct.
Okay, so they weren't never considered to be an add-on. They were just considered to be
limited term.
We have a problem.
Right.
We're going to deal with this problem. We see it being temporary. This is the temporary time frame, and now you should be in this temporary time frame up to par.
Correct.
Okay.
Correct, but it's been
But the issue is really it's not up to par, because even with our staff fully, every investigator vacancy filled, that's not going to be enough people to deal with the workload. So that's really the significant issue. And I'd also like to point out, back in 2010, the board did receive approval to hire 20.5 non-sworn positions. That was in addition to the sworn positions. And I believe to date they've hired 6. So there's still that gap.
I would just like to correct the record on that. So we had 20.5 positions, of which all but the ones we currently have were swept under budget letter 1203. So
No,
we do not have those positions. Thank you.
Yes, and I would fully like to acknowledge that as well. And so the board wasn't able to fill them, but I guess my point in bringing it up is just a decade ago, it was recognized that this was needed. So for whatever reason, if the positions got swept and the board couldn't fill them, now's the time to ask for them again.
Okay,
We're just trying to maximize efficiencies, going forward.
Okay. Dr. Yip?
Just want to clarify, I heard you mentioned some of the investigators working, quote unquote, the nursing cases. Do you have investigators exclusively work for medical board cases?
So for all the HQIU investigators, the 77 positions, we work exclusively for the medical board, and then we also do cases for the physician assistant board, the podiatry board, and the board of osteopathic medicine only.
Any other questions, comments from members? Okay. Thank you, Mr. Chris and Ms. Nichols.
Thank you.
We appreciate it. Are there any comments from the audience?
I'm presenting this case that came into me last night, actually, through the heavily touted 3.3 out of 5 rated medical board app, which also recommends that it's appropriate for children 4 and up. So let's see if you guys think that children 4 should be privy to this case. Plus, also, too, we're also still getting tons of notifications from the app that we can't figure out. You click on them and you go to the doctor's page and we don't see any changes. This doctor from Chowchilla was charged in his accusation with sexual misconduct with 2 female patients. Oddly, though, none of the actual charges headings are sexual misconduct, which carries a minimum of probation of 7 years according to your minimum guidelines. Instead, he was charged with incompetence and repeated negligence acts, which only carry 5 minimum years of probation. Regardless, in his decision, which just came out last night, he was only given 3 years of probation. The minimum is 5 for the 2 that he was actually charged with, but 7 for sexual misconduct, which is actually what he did. Is it any wonder why so many doctors are offending and sexually assaulting patients when the board protects them over patient safety? Do you all really find this acceptable and in the name of patient safety? I mean, if you read this thing, I mean, he kissed her on the cheek and used the F word while in the physician examination room. During the physical examination, the respondent instructed the patient to stand up from the examination table she was sitting on, and then the respondent kissed her on the lips. This is sexual misconduct, but he wasn't charged with sexual misconduct, which has the higher probation minimum. What's going on with these things? Why are egregious crimes being bartered down so that they can get less probation time? This is not patient safety. This is doctor protection. This is not your job. You guys need to be concerned about this and look into these cases. I read every single accusation and decision that comes out from this board, every single one, word for word. And you know I do because I find all the typographical errors. You guys should be concerned about these cases. These cases are egregious. The Timothy Alex Smith case that Dr. Lewis signed off on, the doctor who killed him with an overdose of medication had his charges bartered away, and he got a slap on the wrist for not supervising the nurses. The patient died, and he got probation. Be concerned. Be concerned about patient safety, not doctor protection.
Thank you. Are there any other comments from the audience?
Yes, Dr. Ree here. It's interesting sitting here before you. As we know, we do have concerns with the investigative unit. Whenever there's a policing force, investigating force that's not racially diversified, and then, so for myself, having attended voluntarily to go to 3 PACE courses, including anger management, which I learned a great deal about myself, my colleagues. It was a wonderful experience. So when we have the HQI unit here and we review their information online, we see that they are just not racially diversified. And then for myself too, having attend the PACE courses, 3 of them now, and seeing that, wow, look at all the physicians here, all the underrepresented minority physicians here, and then of course the complaints to the board about African American physicians being investigated at a higher rate. And then putting that together with today's lecture about the racial disparity in patient treatment, it's understandable. So I encourage you again to not lower the standards of the medical consultants that we hire to work for the medical board, in just so that we can fill some empty seats. but make sure that that we really try to find medical consultants that see a diversified patient population, because that would add to, I believe, to add to decreasing the racial disparity in underrepresented patients. It's that kind of loop that I guess someone like me, having gone through the process of being investigating and then going through the PACE course and then being a co-founder of Black Patients Matter, I understand that disparity. And I don't know that if you've ever been exposed to a speaker that has had that experience that can close the gap and close the loop, but I guess I am trying to. Thank you.
Thank you. Are there any other comments? Any comments on the phone?
No comments from the phone at this time.
Okay. Moving to agenda item 22, an update from the Department of Consumer Affairs. Mr. Lay.
Hello. President Pines, Vice President Lewis, Executive Officer Kirkmeyer, members of the board. It is good to see you all in beautiful Los Angeles. As a point of personal privilege, I lived many years in and around the LA area, so it's always a treat to be back on the old stomping ground, especially when we know we're only a few miles away from some of the best Vietnamese restaurants in the world. As always, thank you so much for providing the Department of Consumer Affairs an opportunity to provide an update to your board. For the purposes of the minutes, my name is Patrick Lay. I'm the Assistant Deputy Director for Board and Bureau Services at the Department of Consumer Affairs. My first update is regarding the Department of Consumer Affairs Director, which E.O. Kirkmeyer alluded to in her report yesterday. As you very well know, Mr. Dean Grafilo has retired from the post of Director this past April. We are incredibly grateful for his service and for his leadership, and we absolutely wish him the best as he starts a new and exciting chapter of his career in the private sector. We are looking forward to be working with the governor's office in ensuring that we work through a smooth transition and as we prepare for a new leadership here at the department. And in the meantime, we're really appreciative of your patience as we undergo this time of transition. My next update is regarding the executive officer's salary study. And as you recall, the department had retained KH Consulting to conduct an executive officer salary study. The study aimed to do a deep dive analysis on the programmatic evolution of all DCA boards over the past few years. It aimed to do an examination of the processes used to submit a salary increase and the factors that come into account for approval or denial. And it also aimed to do a benchmark comparison of salaries in different states. Unfortunately, we had a delay due to that last factor, the benchmark comparison of other states. We had some issues getting information from other states, so we had to extend the timeline because we wanted to make sure that we had the relevant information, comparable data of salary information from comparable programs, similar in mission and similar in licensee population from other states. Thankfully, we now have gathered and synthesized all of the information that we needed, and we are very close to release and are in the last stages of review and of approval, and we aim to release the executive officer's salary study within the next few weeks. We truly appreciate your patience as we finish this project up, as we know this is a very critical project for our DCA departments. My next update is regarding the Substance Abuse Coordination Committee. And as you know, last year in 2018, the Substance Abuse Coordination Committee voted to make minor technical changes to Uniform Standard Number 4, which guides the protocols around drug testing standards for licensees who are substance abusers and in a diversion program or a probation program. As you know, the committee also voted to examine other uniform standards and determine if any other changes or additions needs to be made. As you very well know, there are 15 other uniform standards that guide anything from the initial clinical evaluation to the requirement having participation in group meetings or having a worksite monitor or data collection. So to that end, this week, the department has deployed a survey to all executive officers as well as stakeholders to get a sense of what are the common threads or the common topics that we may engage in terms of modifying or adding onto the uniform standards. So we will be keeping a close eye on the results of the survey and see what we can come up with. My next update is regarding the Technology Advisory Council. It is an exciting new endeavor led by our Deputy Director of Office of Information Services, Jason Piccioni, which kicked off this past March. This council aims to provide guidance on how the department can use technology and innovation, existing technology or emerging technology to improve our day-to-day operations. So far, it's really high-level concepts, but concepts such as how can we use artificial intelligence or machine learning, which are extensively used in the private sector, to provide direct-to-consumer customer service or provide automation for some of our day-to-day business processes. Some of the other concepts are how we can integrate current information technology platforms, which are very varied across DCA, into a more seamless and smooth experience, or how to upgrade our security solutions to make sure that all private and sensitive information are safeguarded or continue to be safeguarded whenever a consumer interacts with the Department of Consumer Affairs. Excited to see what the Technology Council will come up with, and we'll provide you updates throughout the year. My next update is also a technology one regarding the DCA Open Data Portal. Excited to announce that we launched an open data portal. It's a publicly available one-stop shop for all licensing and enforcement data across all DCA boards, bureaus, and commissions. It provides anything from numbers, data trends, summaries that can be cut in various different ways. On the licensing side, users can see active license, renewed license, pending applications for a license. On the enforcement side, users can see volume of complaints, average cycle time for investigation and formal discipline, and all this information can be downloaded in Excel, PDF, PowerPoint, and really the goal is to make DCA data more transparent, more accessible, and hopefully have a tool for stakeholders to help us see data points that we may not see and improve our operations. As a self-proclaimed data nerd that doesn't have any credentials, I'm really excited about the Open Data Portal. So whether you're a board member or a member of the public, I highly encourage you to check it out at www.dca.ca.gov. And on top of the page, you'll see a tab called Data, which you can access and where all the magic happens. And my last update is regarding a question that I got at the last board meeting. One of the board members asked me about the status of reclassifying board staff from inspector positions to special investigator positions. I did not have an answer back in February, but I do now. Wanted to report that on June 29th, 2018, DCA submitted a proposal to CalHR, which is the state's department that does all position classification and salaries. And we submitted a proposal to reclass the board's inspector positions into special investigators. CalHR subsequently requested that DCA conduct a desk audit of the positions. So DCA did so and submitted a report to CalHR on February 1st, 2019. CalHR has since denied the proposal to reclassify the board's inspector positions. So our human resource department, that is our internal DCA HR department, has been working very closely with board staff to identify alternative solutions that will be best to support staff, management, and the board's mission of protecting California consumers. So with that, that concludes my update, and I'm happy to take any questions that the board may have.
Thank you, Mr. Lay. Dr. Gananadev?
Mr. Lay, I'm at least somewhat glad to hear that the executive compensation is getting somewhere. It started when David Serrano Civil was president. I tried my best for 2 years, so the 4 years went by, and now it's the 5th year. I mean, if a private sector moves like this, those companies will be under. So I'm hoping that by the next meeting, you said in a few weeks, so you will have the answer for us, I hope, right?
Yeah, we're definitely hoping to commit to release the the report in the next few weeks.
Yeah, we do not want to lose good people, and as you know, it is our money. It's not general fund money.
Completely
Thank you.
understand.
Any other comments from members? Okay. We do have a comment from the public. Mary Ann Hollingsworth.
That we've been having terrible problems with the phone issues. I know I've been texting a lot with another advocate who really wanted to comment about a couple things. The phone line went down 3 times yesterday and went down just now, and this person wanted to make a comment about the DCA report. And just to let you know, it's been very frustrating, so hopefully you'll be able to get the video up soon so she can see that and be able to know. But it is a problem for people trying to call in. They've been very good at notifying people that the phone line is down when it does, but the fact that this is preventing people from giving their comments is a concern, so maybe you can work on that for the next meeting. Thank you.
If people want to send their comments, they can send their comments who had problems. They can send it to the office staff, and the office staff will get those comments to us. Okay. Okay.
Are you surprised? Just thinking on that, I wonder if somebody could monitor a Twitter feed or something for when problems like this come up. Somebody could actually tweet it in, and at least it could be brought up or something.
So we have people that are on the phones listening as well in our office, that when the phone lines go down, they take care of it. It's just technology.
Well, except that the person that I spoke to said that she called in a second time and they refused to let her speak.
Well, we'll have to look into that.
Okay. I saw the data portal, and while there wasn't anything in there that I don't think I would ever use, I really appreciate that you guys are doing that and putting the information out there, and would like to request to be able to see even more, especially when it comes to the medical board, searchable reports that are meaningful to people. For instance, we've tried to do Public Record Act requests to get just lists of all the doctors who are sexual offenders in a certain city or even in the state, and we've been told, no, we have to pay thousands of dollars to have the computer program reprogrammed, and we can't have the information. So we would like to be able to search and get that kind of data portal information for important information like that. Thanks.
Thank you. Are there any additional questions in the audience? Comments? Any on the phone? Oh, hold on one sec before we go to the phone.
My apologies. Just one final comment. In regards to cases that are being investigated and they're taking quite a long time, apparently in other types of like criminal cases that take quite a long time, they would be dismissed. So I would maybe suggest or propose to the medical board that, look, if it's taking 2 or 3 years to investigate a case, maybe they're trying to fit a square into a circle hole or something. Maybe, there is nothing there is the point. So with all these complaints coming to the medical board, I'm very concerned about cases being selected for other than honorable reasons to be investigated. So that's all. Thank you.
Thank you. Any comments on the phone?
Any comments on the phone?
At this time.
Okay. Thank you, Mr. Lay.
Thank
we
you for
appreciate
having me.
it. So before we go to our final agenda item, which is 23, I would like to recognize 2 individuals who on June 1st, 2019, will complete their terms. And so I want to take a moment to thank them for their work. Dr. Bolot is one. Dr. Bolot has served on the board since February of 2015. Dr. Bolot is our current board secretary. She has served as chair of the Special Faculty Permit Review Committee, chair and vice chair of Panel B, and has served on the Enforcement Committee, Executive Committee, and the Midwifery Task Force. She has been a strong leader on the board and has shown her passion for ensuring that the board meets its mission of consumer protection. She has also been a voice to ensure California has the workforce it needs to serve underserved areas. Dr. Bolot, we'd like to present you with this plaque and say thank you for your work on the board. It's been invaluable.
Thank you.
President Pines. Lovely. This is beautiful. Thank you so much.
Would you like to say a few words?
I would.
Okay.
I want to thank. Let me use the microphone. Get in trouble. This, when I got the call from the governor's office, it was probably one of the most difficult calls I'd actually had. Being on this board was something that was very important to me. I represent about 6% of the physician workforce. And being a woman physician, which is also, sometimes I walk into rooms and they say, "Are you the nurse?" So that still happens. So what is more important to me is that this work of the board continues. I think the consumers have done an amazing job from when I started to being able to start to articulate what it is, the needs of our members. And I would just say this: I love my profession, and I am very proud to have served on this board. And I just want to also end by saying I've learned from every single person that has joined this board, and I just have enjoyed it so much. So thank you all very much.
Thank you. The next person I'd like to recognize is Jamie Wright. Jamie had to go to court this morning, so she wasn't able to join us for her final board meeting. Ms. Wright was appointed to the board in August of 2013. Ms. Wright has served as chair and vice chair of Panel A, and has also served on the licensing committee, enforcement committee, and the disciplinary demographic task force. Ms. Wright has used her legal background to find ways to improve the board's processes and has been a strong public member and a patient advocate. Ms. Wright, we want to thank you, even though you're not here, and this is recorded for her, to present her also with a plaque and recognize her work that she's done here in California. So now I will go to the final agenda item, which is our agenda item 23, future agenda items. So I'm going to start myself. I have a few. So the first one is to get an update on a demographic study, and that can just be a report presented in the executive director's report. A presentation on the state of maternal health in the state of California. This has come up a couple of times. I've actually brought it up myself, but I think we need to understand what the real issues are as a collective group, especially for those of us who are lay persons and those who are also not practicing in maternal health. And the next one would be around telehealth medicine. We sort of heard a lot about that today, and I know we've had presentations, but it's been at least 3 years that I can remember on this particular issue. And the way I heard some of our problems and challenges as it relates to people of color and poor people is that this could actually be a tool that we could use. So I'd like to hear more about that. And then finally, a discussion on the proposed conscious objection rule, which will permit healthcare providers to refuse to provide care if they claim the procedure offends their conscience. So I think that's really important and going to be a bit challenging in this state if we move forward that way.
Can I
yes, please do.
I just wanted to let the members know that on this last issue that Ms. Pines asked for a agenda item, it is something that actually time is of the essence as to when these regulations are going to be released. And so we were probably going to have a telephone conference within the next month. So I just wanted to put that on. We will try to get out dates to you as soon as we get back to the office on Monday to try to match calendars. It might be one, I know with everybody usually working during the day, it might be in an evening time, but we will try to get a meeting on the books as soon as possible.
Yeah, it is an urgent matter, so expect communications to go out very soon and asking for your immediate assistance to get a meeting on calendar.
Are there any?
Kim and Kerry. So if federal government does that, but state of California doesn't agree, does that still affect us in healthcare?
It could. Carrie will answer, but I think where we would be coming from is it'd be similar to a while back when There was law on the End of Life Option Act. We actually did a declaration for the Attorney General's office as to how it would impact the board, and I think it would maybe look something more like that as to how we join on, but it would impact us ultimately, yeah.
Okay. Okay. Does anyone have any future agenda items? Okay.
One item I'd like to see at some point is with respect to expert reviewers. And I'd like to know, I mean, from my understanding, there's a bunch of areas where we need more specialists in various areas. And so I'd like to understand what our efforts are in recruiting in those areas. And perhaps we can also talk about more creative ways to do so and recruit those folks.
Okay.
Thank you.
Anybody else have any recommendations? Okay. Do we have any comments from the public?
Yes, just a real quick comment. As far as the conscious objection, as a physician, it's a very, very important topic for those of us who are on the front lines and practicing that. So for myself, I have my own religious beliefs, and I adhere to them. I depend on my God and all that. So it's a very serious subject. Thank you.
Thank you.
According to the president and vice president, the rules are already in place. Now, I don't know if, we can always trust what they say, but, and on the women's health issues that you brought up, I think maybe we should invite Charles Johnson to come and speak on that. His foundation is very proactive, and he went to Washington, D.C. and spoke about it and got some things passed on that, so I think it would be a good guest to have for that. And then my usual request, I think this is the 12th or 13th time that I've asked for the Public Records Act issue to be brought to the board. Is nobody else concerned that the board often breaks the Public Records Act? It's so important. Lawyers, the law is being broken. If you can prove me wrong, let's just talk about it and prove me wrong, but I think I can prove you guys wrong. I think the law is being broken, and you're violating. When people ask for certain documents, you're hiding behind exemptions in the law, which are not mandatory. They are not mandatory. You can always say, yes, we will give you this document. The law allows for that. We just need to talk about it. We just need to put it to bed, because I think you guys must be as sick as I am hearing me ask for it. Thanks.
Thank you. Are there any comments on the phone?
We have no comments from the phone at this time.
Okay. We are adjourned. Thank you.